Yeah, we are good to go.
Okay.
Okay, so
Okay, sir. So, greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clearnet serves as a digital partner for this event hosted by Association of Fellow Gynecologists Mumbai. And the focus of today's session is sexual health, her unspoken problems. Now, I would like to invite Dr. Dhaval sir to proceed with the session. Over to you, sir.
Thank you. On behalf of the Association of Fellow Gynecologists and my co-convener, Dr. Neeraj Jadhav, sir from Rajkot, I extend a warm welcome to all faculty and delegates who have logged in today for this extremely interesting topic on female sexual dysfunction, her unspoken problems. Can we have Neeraj sir's CV?
is my slides are visible, sir?
No.
No.
Okay, sir, I'm sharing it again, sir.
Yes, visible.
Dhaval?
Dr. Dhaval, you're mute.
Sorry. Our senior convener for today is Dr. Neeraj Jadhav, sir. Sir has been the chairperson of the FOXY Sexual Medicine Committee 2020 to 2023. He has also won the Best Committee Award in that duration. He has been president of the Rajkot Gynecological Society. And this webinar is his brainchild, as sexual medicine and female sexual dysfunction is a topic that is very close to his heart. Over to you, Neeraj, sir.
Thank you, Dhaval, for your kind introduction. So, at the outset, I would like to thank AFG President Dr. Nitin and AFG Secretary Dr. Bela Bhatt, who agreed to be arrange this webinar that is on sexual health, because it's not taught in our topic. We as a gynecologist are also not that much comfortable to discuss about this topic. But if you go by the prevalence rate of the female sexual dysfunction, it is around 30 to 40%. So every third patient entering in your chamber have some sort of sexual dysfunction. So basically, sexual medicine is not a recognized branch. There is no special MCI courses for that. So many different pathies are involved in it. Like psychiatric people are doing sexual medicine, then there is skin VD people, then the andrologists also are doing the sexual medicine practice. But we gynecologists are somewhat shy when it comes to the sexual medicine. But believe me, our female patient is not comfortable going to these sexologist people. So they have very close rapport with we as a gynecologist. They can discuss their intimate problem with us. And so it's our duty that we should know about sexual dysfunction, sexual health, how we can manage different type of sexual dysfunction. So basically, when I was chairperson for 4 years, I tried to go to different society by webinar, by CME, and try to sensitize our fellow gynecologists so that they can start taking interest in the sexual medicine. They can have some basic knowledge about the sexual medicine, and they can comfortably manage problem of the patient. So thank you all the AFG office bearer and all the panelists and all the speaker and all the chairperson who has joined today's for webinar. With that note, I welcome everyone for today's webinar. Thank you.
Thank you, Neeraj sir, for that introduction. I would now like to invite Dr. Nitin Shah sir, our dynamic and charming AFG President 2025-26, to please say a few words. Over to you, Nitin sir.
Yeah. So Thank you. A warm welcome to everyone who has joined this webinar. And I think we have crossed more than 500 count for this webinar. So I welcome all the delegates and faculty. And today's our webinar is on the sexual health, female sexual health, her unspoken problems. So this is a major chunk in our practice, what we have noticed, and they don't come out so easily. So this was my focus that we should have discussion on this part. And I think Neeraj Yadav sir being a Foxy committee is there to help us in this. And we have a wide variety of faculties who are going to share their experience. So as a AFG president, I will start with our song for the year. Visible?
Sound is not there.
Will come. 20 seconds. Now.
We are the guardians of women's health, dedicated to caring with compassion and wealth. From pregnancy to menopause, we stand by their side. With expertise and empathy, we guide them with pride. United we care, what women we serve. With skill and with heart, we strive to deserve their trust and their faith in all that we do. United we care, for me and for you. Verse 2, from routine checkups to complex surgeries too, we work together to see our patients through. With every birth and every new life, we celebrate miracles and the joy that they bring to our strife. United we care, for the women we serve. With skill and with heart, we strive to deserve their trust and their faith in all that we do. United with care, for me and for you. We are the advocates for women's rights and health, who stand together to break down every wealth of inequality and injustice too. We are the champions for the women we serve is true. United we care, for the women we serve. With skill and with heart, we strive to deserve their trust and their faith in all that we do. United we care,
Yeah.
for me and for you.
Good. Tell me. Yeah.
Nitin sir, can we go ahead?
Yes.
So that was our AFG song, again, something that is special to 25-26 at AFG. Like many other
One
things.
more thing, I will just share our today's academic partner. So I'll just highlight in a moment. This is not going. Just one sec. Okay. So today our academic partner is SOCAM System. They are surgical grade monitor, the makers and distributors. They have all sort of medical grade monitors and video recorders from the Sony. So this is that contact number for SOCAM, Mr. Kaushik, and their location is Malad West at Sage Plaza. So we thank our sponsors for today. I think we can go ahead, Dhaval.
Yeah. Thank you, Nitin sir. Without any further delay, I would like to start today's scientific program. First up, we have a very interesting panel discussion. Can we please have the CVs of the moderators?
Sir, can you please go through with the names?
Neeraj sir? Yeah, Dr. Neeraj Jadhav sir. Dr. Poonam Mishra. Poonam Madam is the director of Manas Hospital and Manas Gynec Cosmetology Center at Lucknow, and she's also the president of the Indian School of Aesthetic Gynecology.
Yes. Good evening, sir.
Welcome, madam. Next slide, please. I'd now like to introduce the panelists.
Well, we will introduce our panelists in panel only. If there is, okay. If there is, yeah. Okay, you can go ahead, Dhaval. Dhaval?
Dhaval, you're muted.
Yeah, our first panelist is Dr. Indu Singh. She is senior consultant at Aditya Birla and presently she's director at ICGL. Welcome, Dr. Indu. Next slide, please. Our next panelist is Dr. Parul Savji. She's the director of Oracle Clinic at Nagpur and she's also chairperson of the AMOG's Young Talent Promotion Committee 24 to 26. Welcome, Dr. Parul. Next slide, please. Our next panelist is Dr. Vaidehi Thakur. Next, please. Dr. Vandana Bhuria is our panelist. Welcome, madam.
Thank you.
Next slide, please. Our next panelist is Dr. Madhu Kiran. Madam is senior gynecologist and cosmetologist at Kensho Wellness Clinic at Uttarakhand. And she has a special interest and a fellowship in aesthetic medicine and cosmetic gynecology. Welcome, madam. Next, please. Our next panelist is Dr. Siddesh Iyer. He is consultant at Saukyam Hospital and has been postgraduate teacher for many, many years. And he is MRCOG examiner. Welcome, Siddesh. Our last panelist for today is Dr. Vindhya Bandukwala. She is consultant OBGYN and director of the Touch of Joy Women's Clinic and Fertility Center and founder member of FEPA and a core member of GIBS. Welcome, Dr. Vidya.
Thank you.
Over to the moderators, please.
Thank you, Dhaval. So let me share my screen. So, welcome everyone for today's panel. That is her unspoken problem. That is about female sexual dysfunction. So I welcome everyone with my co-moderator, Dr. Poonam Misra, and all the panelists who are introduced by Dhaval, Dr. Indu, Dr. Parul. Dr. Vaidehi is not there, so Dr. Queen will be replacing as a panelist Dr. Vanna, Dr. Madhukiran, Dr. Siddesh, and Dr. Vidya. Welcome all the panelists. I am sure with your input, we have a great discussion about the female sexual dysfunction. So, this was a survey done under Sexual Medicine Committee 2 years back, where we asked our fellow gynecologists about whether they have any training in the sexual medicine. So around 9% of our friends have some course related to sexual medicine. Around 32% of our friends have some exposure to CME related to sexual medicine, while around 62% of our fellow gynecologists have no exposure to any sexual medicine subject. So that is a very bad scenario. And I hope in coming days, this figure will come down drastically with the help of this type of CME and webinars. So with that, let's start with our panel discussion. Dr. Poonam, you can start with the first question.
Yes, sir. Thank you so much for at the outset. I would like to thank you to involve me as your co-moderator. It's a privilege, actually. So the first question is going to Dr. Siddesh. What is sexual health? A very important one. Dr. Siddesh, has he joined? I don't think
He's muted.
Yes, he is there.
He's
Yes,
there,
sir.
but he's
Yes,
muted.
yes, Dr. Siddesh, you
So
are
can you
quite
hear me?
visible.
Yeah, hi.
Very
So,
nice.
hi.
Welcome.
So, Thank you so much. At the outset, I would like to thank AFG and all the seniors around, moderators and panelists for making me a part of this panel discussion. And I would like to say that I am probably one among those 62% with no formal training in cosmetic or aesthetic gynecology, but I do practice because I do fertility as one of my specialities. So, honestly speaking, just like health is a state of physical, emotional, mental, social well-being, I think sexual health is taking the same thing to a step further, and you're looking at sexuality and having proper sexual life. So it requires a positive, respectful approach towards sexuality and even sexual relationships. And you look at situations where you have want to have pleasurable sex, safe sexual practices, and you want to make sure that you're enjoying your sexual practices safely. So this, according to me, is what is sexual health.
Perfect.
Exactly. And this is according to WHO also. Yeah.
Thank you.
Okay.
So, whether it's not that, Dr. Queen, can you just elaborate? Because it's very important to understand the sexual response cycle, to understand the sexual dysfunction. So, Dr. Queen, can you just describe what is the sexual response cycle?
Usually it is considered to be linear, the linear pattern. So in that form, it comes as first the desire, after that the arousal, after the arousal, the intermission, and then finally the orgasm, followed by the resolution. But according to Masters and Johnson's, it starts like the excitement, play two, then the orgasm, and finally the resolution. This is how it is looked upon, but sometimes it can be non-linear also. That is according to Rosemary Basin, it can start from anywhere, not necessarily from the desire. So that is how it can vary.
Yeah. So basically, Master and Johnson introduced this linear model, but so many things are not explained by this linear model. So nowadays, this model by the Rosie Besson has been more scientifically approved, and it is a more accepted one, because female sexual response cycle is a very complex thing, and so many things are involved in it, and it's not that much simple and linear.
Sir, you all say that women are complex. So that is why it will anyways, involving a woman, it will be complex.
As a male, I can't say, otherwise you will all be.
No, I am volunteering the information that all women people say itna seedha nahi hai, tere hai. So that's why
women can handle all type of complexities. Why don't you understand? That is why God has given everything in a complex way.
So that is why the linear model is not nowadays. We are more or less accepting the model given by Rosemary Basin, and where it can start from any point. So,
any other panelists want to add anything about the female sexual response cycle?
No,
any panelist can just, if you want to add anything, you can add.
No, I think Dr. Queen gave a elaborate understanding. So I think.
Okay.
Yes, complexity is definitely there. We'll break through the complexity. Yeah.
So the next question is going to Dr. Vidya.
Yes.
And what is female sexual dysfunction as such, which is our topic today?
So as we all understood that sexual health is very important, and it is the distress that a female shows, or when she comes to a consultant with the distress, that's when we label her as having female sexual dysfunction. And it implies when a female undergoes a persistent or a recurring problem where she encounters a difficulty in her sexual response, which is impacting her sexual desire, her arousal, her attaining orgasm, or if she's having pain during sexual activity. This is a distress for her, and it is now impacting her personal life, her quality of life, and her interpersonal relation with her partner. Now, if this is not there, we cannot call it dysfunction. So the presence of distress, which is the key definition of dysfunction, has to be there, and it negatively affects her relationship. So for me, this is female sexual dysfunction. And it is complex because it has multifactorial factors such as psychological, biological, and of course the social factors. So all this put together will be in the definition.
Yeah, so you perfectly said about what is the female sexual dysfunction, and most importantly, she should be have a distress about it. Otherwise, it should not be.
Otherwise, it cannot be labeled.
Neeraj sir,
Yeah.
I'd just like to add one point, as
Yes.
they have very nicely has said that yes, someone might not be having any interest in it, and still they are happy. So that is fine. So I cannot call it a dysfunction,
Yeah.
but there is dysfunction because of the it's the distress, personal or interpersonal distress, and along with that, it has to be persistent. Once or twice it has happened. Suppose somebody says on the first, giving the lady back the second day कि आपकी ये बहू जो है इसको तो कोई interest नहीं वापस ले लो, but that also we have to stress that it has to be persistent as well. Like it is going on for quite some time, then only one off situation we cannot stamp that as a dysfunction.
Yeah.
And the
but
latest, yes. And the
yes,
latest
Dr.
definition
Please, but
says,
sometimes what happens, due to lack of knowledge, some women will be not distressed about it. Suppose so many women don't know about orgasm, so they are not bothered whether they get orgasm or not.
What happens in such a relation, if a female is not knowing what is happening, the man definitely will show the distress, and somehow the couple will come to the consultant.
yeah. So the definition says that if that distress is being sustained for 6 months,
that's what I
then
said,
only it
persistent.
comes
So
under
it has to be
it
persistent.
comes
Only
under the
one after,
definition of sexual
immediately after
dysfunction.
marriage, she is not comfortable.
Yeah. There
And
could be
so then you cannot
performance
stamp her that she
anxiety.
has a
Yeah, there would be performance anxiety sort of thing,
Yeah.
and the male is not able, or the
or
female is
shy.
not able
She's
to
shy. Might be
participate,
new
and that is
environment altogether. Might not be
exactly
comfortable.
very
So
rightly said.
some people
Yeah,
can take time to open up. So all of that
exactly.
combined. So it has to be persistent. So a minimum of 6 months
Should
has
be
to be
there. Yeah,
given.
that
Yeah.
dysfunction should be there. For and to entitle it as a dysfunction, there
Yes,
should be
yes,
a time limit, more than 6 months. Yes.
But-
So,
I want to
Yes.
spill the cat among the pigeons. Now, suppose the female doesn't know that she's not orgasming. Do we as consultants make her realize and then put her into distress, or leave it at that?
No, I think
If the female
yes,
doesn't know,
yeah.
she will not report to you, sir.
So suppose,
And
suppose
it
now
will
on
be
my
only
question on
dysfunction.
sexual
It will
history,
be only dysfunction if she's distressed by that particular
so we
problem.
leave it at that. No, we don't bother into that.
It's
Huh.
not
We don't
about
delve into that
that.
territory at
Siddesh,
all.
I had
if
a
a
patient-
patient comes to you, then she's in distress. If she is not opening up, that means she's not distressed.
so
I want to
a
give you a small
consultant,
instance. I had a patient who had come for infertility, and then finally she conceived and everything. And when later on I spoke about these issues, she asked me, does someone engage in these activities for any other reason than for producing a child? Like after having the child, she's asking me, is there any other reason that a woman will, for a man, I have heard that they enjoy, but for a woman, is there any other reason? That lady asked me categorically after she went through the entire process and
No,
also
Dr.
born
Queen,
a child.
that is the taboo we are surrounded with. And that is the reason now we are opening up. And
that is why a sexuality education and sexual
Absolutely.
awareness is the need of the time.
Exactly.
So she should come to you herself that yes, she has never attained that orgasm and other things. So our duty is to make them aware also and give them treatment. Dr.
We
Neeraj.
also had a similar patient, Poonam ma'am. She was married for 9 years, conceived through IVF, and had never had an orgasm, or in fact, she was not even interested. She was like, I just thought that this is one thing for which I can have a child with. And she came for the second child planning now. And that is when I told her, these things are also an integral part of a married life. And for a woman to feel complete and whole. I mean, that's such an important thing. But I think, and she was pretty educated from Chennai, and still, having things like these in her head.
In this
Education has
country,
nothing to do with the sexual health.
in this country, many women are like that.
No,
I
not
have
only
noted, I'm sure
many
all of you.
women, even the couple. Basically,
ma'am, we have
coincidentally, they meet a partner who's also unaware of all these. And somehow they come late to see us.
But scenario is changing now.
ma'am,
Yes,
we
yes.
have to explain them.
Yes,
Like
exactly.
orgasm is not for kids. Like they can produce kids without orgasm also. Orgasm for
It's
intimacy.
not required,
and for
obviously.
healthy relationship.
Orgasm is not required actually.
Not
females-
required, not
So,
that is-
but
Yes,
nowadays
ma'am. So we
scenario.
have to explain them. They are not understanding that things. They are thinking everything is fine if they are having kids.
exactly.
I think this discussion may go on.
Sexual satisfaction is
Exactly.
a
Poonam, you can stop it, I think. I'm sorry.
Yeah.
We
I think we
all
should
said
go
just
to
to
the
make
next
it a little
slide.
interesting.
Exactly.
yes, Poonam.
Sir, the next question is going to Dr. Madhu Kiran, madam. So, would you please classify the female sexual dysfunction?
Thank you, madam, for including me in this panel. Actually, initially we had a very difficulty in understanding how the sexual activity occurs, and it was in the late 90s when Masters and Johnsons gave their first insight into the linear model of sex, that we were able to give some sort of classification to sexual dysfunctions. Nowadays, what we are following is the DSM classification, which initially was divided into five. That is, we had classified hypoactive desire and arousal disorder as a different entity, and we had kept dyspareunia and vaginismus as a different entity. But nowadays, what we are following is the DSM 2013 criteria, where we have merged the arousal and interest disorder as one. So now we have one as female sexual arousal and interest disorder. The orgasmic disorder remains the same as was the previous one. And now we have also combined the dyspareunia and vaginismus problem as one, as female pelvic pain and penetrative disorder. So this is the major three chunk that we are looking for. Otherwise, there is an unspecified category also, where drug-induced or unspecified causes can lead to sexual dysfunctions. So this is the criteria we are following nowadays.
Very nicely elaborate. Very nice. Thank you.
So, Dr. Vanna, can you tell why we should be thinking about the sexual dysfunction, how it will affect the woman and the couple as such?
Sir, very rightly said, there are deleterious effects on the women's mental health, as leading further to the physical health, which can due to the sexual disorder. Mentally, she can have low self-esteem after the diagnosis of sexual disorder. She can have low self-esteem. There's a sense of futility in her, further leading to frustration. And all these can lead to psychological problems like anxiety, depression, worry, unhappiness, and irritability. These psychological problems further can affect the couple, and there is marital disharmony, which further leads to disturbed interpersonal relationships, arguments, and there are increased rates of divorce nowadays due to all these problems. Infertility can also be there because of women can feel like that there is she cannot produce children because there is sexual dysfunction in her. In males, there can be premature ejaculation, erectile dysfunction. Further, all these problems can lead to divorce. And nowadays, many cases of divorce, the basis of the divorce is a sexual dysfunction, either in the male or the female. So we need to focus on the management of all these sexual dysfunctions.
Yeah, perfectly said, because sometimes what happens, female sexual dysfunction can lead to the bowel problem also. Problem in the bowel. And many times patient will not directly come with their sexual problem. They will present with the other complaints, like they are feeling depressed, anxiety, then there will be a couple issue. But when you dig out, then you find that there is some sexual problem is
In
there.
fact, some of them
Subse zyada headache.
pain, they come
Most
with
of them, they will
pains
present
also.
with generalized weakness
One
and
by one,
anxiety.
you can just, otherwise it will be one by one.
Okay.
Yes, yes.
But just as I was saying, most of the females, they can present with generalized weakness and anxiety only. And then from further digging the history, then we come to know that actual problem was sexual dysfunction. There's a sexual taboo in our society. The patient doesn't want to discuss anything with either their family or the doctors. So we need to break that taboo actually, so that we can lead our history to the basis of the problem, what is the problem lies. So on digging the history, we can, reach to the problem of sexual dysfunctions.
In fact, some of the patients, because they don't want to get indulge into sexual activity, they label themselves as having sexual pain, pelvic pain, and they will come to the gynecologist with pelvic problems. So they will not directly come. So it is for us to, probe into the history. So very important in sexual pain. I won't say sexual pain, in any pelvic related issues with the patient. You must probe into their sexual health. Very, very important.
तो बहुत simple सी
they can give you the
बात है कि
religious
the
causes
label.
also. Okay, this is this and this is that.
Yeah.
Yeah.
And also
Yeah, yeah,
patients of infertility, we need to ask about the
yeah.
sexual frequency, their sexual history, because most of the time the people that do not know that sexual intercourse is required for producing children. When the patient comes with infertility, then we come to know that there had been no sexual intercourse, and there may be some, rectal intercourse, or they do not know the exact point where the sexual habits can be indulged, how to indulge in the sexual intercourse. So we need to talk with our patients more.
Exactly. And the fact is, if she is regularly getting the sexual pleasure, headache वाली problem नहीं होगी, जो होता है ना कि हर दिन फीमेल को headache हो रहा है. So कुछ है ही नहीं, उसकी life में नहीं है, तभी तो हो रहा है. So problems are there just because she is not getting that orgasmic pleasure or some sexual pleasure. So that is why the sexual awareness again.
Also, one thing I want to add that
Yes.
sometimes the male comes up with a problem of erectile dysfunction, and actually, when somebody is taking fertility history, you realize that the female has had a vaginismus issue, or she has lack of arousal, and that husband who gets erect does not hold the erection long because he's probably a little sensitive to his wife's needs, and he's a little affected, and then the erection is gone, and they come for the male problem, but actually, it is a female sexual problem which has triggered the whole male problem.
Exactly. So, Dr. Siddesh, there has been proven association of vaginismus with erectile dysfunction.
Yes.
Yes,
Yeah.
Dr. Neeraj has
Actually,
already
ma'am,
mentioned
IT
this
crowd is
earlier.
the one where we see this problem pretty dominant. I mean, the infertility patients who usually are working in the IT sectors, I think this is a very common problem amongst them. And somehow, I don't know, but that is very true.
I think any prolonged issues then becomes a partner issue. So we have to probe both of them.
Actually, more than 6 months of vaginismus, if we won't treat, then male partner will be having erectile dysfunctions.
Yes.
So many
Yes.
times only we are treating erectile dysfunction, but we are not asking history of female partner.
So now let's move to the first sexual dysfunction, that is a female sexual interest or arousal disorder. Dr. Poonam? Dr.
Yes.
Hindu is there?
Yeah, she's there.
Okay.
Dr. Hindu, I can't see her.
Madam
no
has just
problem.
left for the emergency. She told she will join back. She has just put in the chat box.
Okay. So we should put this question to Nasirgi, I think. Hi, Dr.
Yeah.
Nasirgi.
Yes.
So what is the criteria of FSIAD, female sexual interest in arousal disorder?
So it's like three among 6 criteria. 3 criteria is important to label as a FSAID. Based on those hypoactive disorder, desire disorders, absent or decreased, like sexual interest or erotic thoughts or fantasy. New criteria based on 4 additional aspects of sex life, absent or decreased. Initiation of sexual activity or responsiveness to partners' attempt to initiate it, excitement and pleasure during the sexual activity, arousal in response to sexual clues, and sensation during the sexual activity, whether genital or non-genital. And to make any diagnosis of sexual disorder, 75 to 100% of time, with the notable exceptions of substance or medication-induced disorders, and it required minimum duration of approximately 6 months, deemed to have caused significant distress.
Yes, perfect. So, Dr. Parul, can you just suppose patient is coming to your OPD and she is saying that she is having problem of desire and arousal. So, how will you evaluate this patient?
So,
Dr. Parul,
whenever
yeah.
a patient like this comes into us, I think the screening is very important, and there has been a screener which is available for decreased sexual desire, and it has 5 points basically. The first point being that whether earlier she had ever had an orgasm or not, and whether she was satisfied with whatever sexual desires she had. Secondly, the second point is now the decrease which is there. Has there been a decrease in the sexual desire or interest? Thirdly, whether would she be, wanting that to go back? And fourthly, if she's bothered for the same. And fifthly, the points which she thinks are responsible for her decreased sexual desire. That could be a operative thing, or the partner, or there's some pain or arousal issues are there. So in this, if any of the four, if all of the four are true, then in that case, it is definitely indicative of the sexual arousal disorder. And if any of the four is false, then in that case we have to interrogate, and she does not come into the category of a generalized sexual arousal disorder. And also we need to understand that when was the onset, for how long this has been there, any behavioral changes or adaptations which she has had to make, and the level of distress which she is having to face because of these new changes which are there. And when a patient like this comes, I think the best part is counseling and the history taking, because when you take history, you understand what exactly has been the issue with her, and you need to counsel the patient. Psychotherapy works wonders. And lastly, yes, pharmacotherapy also can be, instigated for patients like these, and that can be helpful for her.
Dr. Parul, just you can help our audience. How will you go about the sexual history? Whether you take from the patient or you take from the husband, how will you go about the sexual history?
Sir, I think we'll take it from both the partners, because there should not be any disharmony in what probably one person is saying and the other person is saying something else. So I think it is always good to have a history from both the partners, so that we can come to a common consensus that exactly what and where the issue is lying.
Yeah,
Exactly.
so
First,
basically
take the
sexual
history
history. Yeah.
from the first.
Yes, yes.
You should first take
Sexual
the history from the
history
patient.
separately as well. Yeah.
Separately,
Yeah, Dr.
first from
Vanna.
the patient, then from the husband,
Separately
and
and
then jointly.
combined.
I think very, very, very important is no patient is going to open up in the first consultation.
Exactly.
So
Yeah.
you have to assure her full confidentiality and privacy. And we should talk to her first, get her to bring out her history. And if she is comfortable in the following consultations, to involve the partner. And I think that is most important, because she will not open up in the first consultation. Definitely not.
Definitely.
And you
We
will
have
get
to
a number of
talk.
informations.
Yes.
Yeah. Because the female is saying something else, the male is saying something else. Many complaints are coming in the absence of the female, and you can get that mental disharmony is also there in between them. So how you have to go ahead in such cases. So that will give you a clues. Yeah.
Dr. Parul, can you just tell us about if patient is complaining of low desire, what type of investigation or laboratory investigation you would go for? Dr. Parul? Parul is there, Poonam?
She was there.
She's not visible, sir. I think which was
Okay. Anyone want to tell us which type of laboratory investigation will help in this case scenario?
So laboratory like thyroid function test we have to do, CBC we have to do. Sometimes ferritin level or that is low, then also they are having tiredness, and because of that they are complaining. Thyroid level may be high or low, then also it will be the problem. Then lipid profile is important.
I think more important is, of course, comorbid condition. We have to rule out diabetes. We have to rule out any lipid dyslip. But also we should try to get her testosterone levels also, because that also could be low, and that could be one of the reason of her having this. And we are seeing younger patients going through premature ovarian failure. We must rule out all those things. So I think there is more the lab test, but few of them.
Any
Can someone
panelist,
elaborate on the
any
value of
panelist will
prolactin?
go for testosterone level?
Prolactin, yes, we
Dr.
should.
Vijay is
Prolactin and DHEA levels are also one of the things which have been known to cause these problems.
So, along with prolactin being such a major part in infertility and ovulation disturbances, I feel prolactin also being a hormone of stress, indicating disturbed sleep, indicating so much of, subclinical anxiety or depression, is also an independent cause, hormonal cause for female and male dysfunction, both sexual dysfunction.
Yes, exactly.
So I would, along with the generic ones like testosterone, lipid profile, sugars, I would also keep prolactin right on top over there.
100%, 100%.
So coming to
And
the
vitamin
management.
D3, B12 and all. Yes.
Yeah.
So vitamin D is nowadays, it's affect everything. So coming to
Universal.
there are three parts. One is the counseling, one is the psychotherapy, and one is the last is the pharmacotherapy.
Counseling, sir, can I take counseling?
Yes, Poonam.
Yes, the next question, this counseling part, we are just throwing this question towards Dr. Indu. Is she there? She's not there, so Nasargi is replacing. Yeah.
Yes,
Doctor. Yes,
most
Nasargi,
intimate
you can.
relationship we have with ourselves, sexual counseling helps make the relationships healthier. In that, sexual counseling provides supportive, accepting, and empathic relationship, so as help to client feel comfortable and seeking the help. And sexual counseling applied to the provision of the advice, guidance in personal, biological, and psychological, even social aspects of sexual life. And it's confidential, safe, and supportive environment, whether they can tell their story, work through their emotion, make positive changes of the life. And for counseling, three models are there. In that, PLITS model, allow, and MEPS models are there. Mainly we are using PLITS model, that is formulated by Annan and Robinson in 1978, and four levels are there in that: permission to talk about sexual matter, fantasy, enjoy, and sexuality, limited information, specific suggestion, and intensive therapy. In the permission, at this level of intervention, the counselor therapist probe about the client's sexuality by asking specific questions, and it established to client that it is appropriate to discuss about sexual health. Limited information, in that we can ask about oral and genital sex, frequency of sexual activity, sex during pregnancy, sex and family planning, and possible effect of medication on erectile response, even any medication they are taking like antihypertensive or other medications, even specific suggestion in that specific coital postures of pregnancy or specific other positions, it's important to ask. And intensive therapy, we can ask about counselor, whether they are having particular counselor, whether they are giving only sexual counseling or about marital counseling, it's also important.
So, according to you, Nesarki, who can go give the sexual counseling? If we as a gynecologist can do that, or we need a psychotherapist for that, or psychologist?
Sir, gynecologist is enough when they are having proper knowledge about sexual counseling, then that is also enough, sir.
I
And
think the
this
first,
explicit model is a very wonderful model, six-stepped approach. So there is that you are approaching the patient, you are taking the permission, you are just asking her, you are understanding her awareness regarding the sexual health. And then you are giving the limited information you are taking and you are giving. Then once you are reaching towards some diagnosis, specific approach is there and then intensive therapy. And this is proving wonderful if a person is just properly interrogating a patient. Very nice.
I think
Yes.
Dr. Poonam,
Mainly, it's like when we are counseling them, we should be comfortable with them. Then only they must be having confidence in us.
and not only that, any woman who has any sexual dysfunction, she's first, because we are the first point of contact as gynecologists. And I think with the brief history, if we realize that she has a psychological component or she has any social issues, then we should refer, because this is not, it is a multidisciplinary.
Unknowingly, we are also following this placet model.
Yes,
Unknowingly,
yes,
we are also
unknowingly.
just doing that
Yeah,
step.
yeah.
Yeah. Very
Exactly, with the
nice.
permission and limited information, we too can go through the model.
And most
And so
importantly,
often when we are just giving those counseling sessions initially by ourselves, a lot of patients understand that what this is leading to, and so they approach to psychotherapy with a much more open-minded interest.
yeah, basically, when you give counsel any patient, not only sexual medicine, you should be non-judgmental.
Yeah.
Because yeah, so patient should be very comfortable in discussing anything and don't
So,
put
having a rapport with the patient is very important. So what you're saying is
Empathic,
totally right.
empathic attitude.
Yeah,
Yes.
you have to show empathy. You have to
Eye
make her
contact
completely
with the
comfortable.
name we have to call. That
Yeah.
everything, one small points is very
Yes.
important.
Yes.
Exactly.
because what happens is sometimes we become too judgmental, and sexuality is a one thing that is a very personal thing, and you have to be non-judgmental. Whatever
Neeraj
patient is,
sir,
that is
Neeraj
fine.
sir,
Yes,
I
yes.
think Rishikesh Pai sir has joined. If you
Okay,
can
okay.
invite them.
Yes, yes, yes.
Great.
I just saw him is there, so we welcome.
Welcome,
Sir.
Mr. Spicer. Thank you for joining from your busy schedule. I know you are out of India, but we all know Spicer don't require any introduction. He was past president. He was president in so many different organizations, and now I think next year he will be figure president. So welcome,
We don't
Spicer.
know. Thank you, Neeraj, and thank you, Nitin, and all of you who are there here. I hope my yeah, right. And
Yes, yes.
a lot of Queenie Aditya is there. Dr. Madhu, Dr. Vidya, Dr. Poonam, Dr. Vandana, Dr. Siddesh, Dr. Bela Bhatt, Dr. I can see Parul Sauji also, and others I can't make out. But my dad was the professor of preventive medicine. He got trained in Harvard, and then when he came back, he to start in the department of preventive medicine, and he was also given the charge of family planning by the commissioner of Mumbai, and they started the family planning department in the F South ward. So during that time, the first laparoscope was brought to Bombay Municipal Corporation from abroad. There were two laparoscopes. One was given to KM Hospital, and the other was in the private in our hospital. So the first laparoscope, one of the first laparoscopes came to my hospital in Pearl Center, where my father trained nearly 1,000 people in the region. So because he was a public health person from all the Suffolk region, it was a regional training center for lab sterilization. So in that process, my father started the network of primary health centers and all. He was in charge of the internship program for all the four hospitals of Bombay. All the medical colleges were under my dad in Kasturba Hospital, and he also started training them in sex education. And one of the medical officers in that training program was Prakash Kothari. Okay, so he was my father's student. My father was not directed towards sex education. He was sex education. He was a family planning person, but he used to he was a great orator. My father, when he was talking, all the people used to come and the full class was full. Otherwise, PSM was always bunk. My dad was a great orator, and Prakash Kotari was one of his ardent students. And then, every time Prakash Kotari meets me, he says, I learned everything from your father. He inspired me. Of course, then my father was into family planning and all that. He was not into sex. So when I did my graduation and I did my MD, I was really bored. Obstetric gynec was not really appealing to me. I was really puzzled. What should I do afterwards? At that point in time, sex thing was coming in a big way, and I was planning to go to USA to Masters and Johnson Institute to get trained. Then I was in confusion. Idhar jao, ye kya karo, endoscopic surgery karo. And then, of course, Indira Hinduja was my boss in KM, and she was doing IVF. So, out of default, I took IVF. So, I would have become a sexologist, but and the sexology was started by my father in India, by the way. You
Yes.
understand? Because Prakash Kotari got inspiration from my father. My father used to have 500 medical officers. They used to be all in episodes where he used to train them in how to do this, how to do family planning, this, how to counsel in sex and all, because he was trained in Harvard University. So they had deputed him. He had gone on a Rockefeller Foundation fellowship. But so he was specially trained in Harvard and sent back to bring public health department into the University of Mumbai. And in that process, the sexual whatever you're talking today is Dr. Pai's legacy, by the way, my
Yes.
father's. Okay, so always a pleasure for me to listen to all this, and the whole thing I feel, and I told you Neeraj that time also when I was president, but I had a lot of ideas, but I could never complete them because unlike here most of the presidencies are for 3 years. So, but in our country, it's not possible to give a president 3 years tenure. But one of the ways of which you can do the training is through digital, because the biggest thing that comes in is awkwardness, barrier. Even if I have to talk about sex to, let's say, a cluster of 90 girls in a class, or it is embarrassing for me, though I'm a doctor, but it's so the human element should be taken out of the communication system totally. Understand? So even if you have a sexual clinic, for example, I would have a AI person talking to them. So when they enter it, the computer talks to them in AI probably. What are you? What is this? So then they are comfortable. After the AI is goes through all the embarrassing questions, then you can start coming in the picture and say, okay. So you can be on more on the therapeutic side rather than on the actually questioning side when they are very awkward and all that stuff. I don't have to tell you, you're all great. And the second part is I'm here for the FIGO presidency. But let me tell you one thing. FIGO presidency is not so I was just wondering. I've gone through entire thing, and there's a high chance that I may lose or I may win because the FIGO, unlike the Foxy presidency, where the presidency is based on ability. See, Foxy president is what You look at the candidates, how able they are, what is their background, what is their reputation, what is their capability, what is their leadership capability. The FIGO presidency is more of alignment. So the ability is not so much, we are all able at FIGO level, all have been present. Alignment, who's friend, which country is which friend, which is a pathetic. I don't agree with it. I feel that election should be on ability, not on alignment. But unfortunately, the FIGO election is totally on alignment and not on ability. So if I win or lose, it's not the same pleasure, because here you are winning because of alignment. One country, for whatever its reason, is helping you to win the election. It's not your own. It's not internally. So what I'm trying to tell you is the Foxy presidency is the peak presidency. After that, it's all. After the climax, na, the end hota hai na, that is the FIGO presidency. So that you come to know after you go through this whole process. I'm here in Ibisoji. I'm chatting with the Italian president, this president, that president. But it's not about ability. It's about alignment. And at our intellectual level, also, I feel sometimes sad that it's ultimately boils down to alignment and not ability. So anyway, these are some of my thought processes, and I feel that the future structure, if I make, and I am thinking of making a future structure in the organizations. I've gone through all the organizations as president, and I feel that the structure which can sustain is the Chinese model. So the Chinese Communist Party. So the future, if I create a structure which I am thinking of creating, it would be a structure which is cylindrical in its structure. Means our structure is pyramidal. You become the president, you fight the vice president, then you become the president, and then you are knocked out. You are out. So after the president, no one will look at you also. But you have the ability to sustain for 10, 15 years after you finish your presidency. That's where we need a new organization to rehabilitate all the past presidents. And so I am slowly in my mind creating a structure where there's no apex. There should be no president. There should be 100, 200 people who run the organization. And suppose Bela wants to do, I want to, sir, want to do something on ultrasound. Okay, Dr. Bela, let's do it in Zurich. Okay, we'll give you 5 companies. This is your account. This is our account. You collect the money, you get people together, do the meeting in Zurich, get a monograph out of your meeting. We can publish it. We'll keep 5 to 10% for the organization. Remaining you take away. That is the structure, the vision which I have in my mind, because I've gone through the evolution of all the possible societies. And if can there be an ideal structure created where there is no leadership? Leadership is collective. Leadership is not an apex, a point. Anyway, these are certain things I wanted to throw at you because you're younger people, you're evolving in your practice. And now I am in the last, my twilight zone. So when I look back and I feel that if I have to leave something behind, I need to leave the cylindrical structure behind before I leave this world. Thank you, Neeraj, and wish you all the best for everything. And all the chairmen who are there, who are fighting, wish you all the best for whatever post you're fighting for. All the best. Thank you.
Thank you,
Thank you,
thank
sir.
you,
Thank you
thank
very
you,
much.
sir.
So much, sir, joining from your busy schedule and blessing us all. Thank you, sir.
So let's continue
Yes,
with
Neeraj,
our
continue.
panel. Yeah. So yes, Naisargi, I think you have finished, no? Yeah.
Yes,
So
sir.
Dr. There is not Dr. Queen. Can you say tell us about the something about the psychotherapy part in the sexual dysfunction,
Yes,
Dr. Queen?
as you
Yeah.
have mentioned, the treatment of FSIAD starts from counseling, then we go into the psychotherapy. And when these are, we feel are not working well enough, then only we go into the pharmacotherapy, which comes much later. So one of the very important aspects or modes of managing these cases are psychotherapy, as you have very rightly mentioned. And one of the earliest forms that is taken up in this regard is the sensate focus. So this means that we don't directly jump what the aim is. Suppose a proper sexual encounter, that is a penetrative sexual encounter, but here we don't jump the gun, we don't go straight into that. What we want to do, the patient is totally uncomfortable, or maybe as a their relationship is such that both the partners are uncomfortable. Now we want to make them comfortable, or the patient herself, we want to make her comfortable, her to be comfortable in her own skin, the way we speak, that she's comfortable about her body parts, about her sexual organs, about her genitals. And here we do not talk about the penetrative sexual aspect. First, making her, it's sensate, like it's from the sensation that comes from there, and so making her comfortable that way. So this is not the goal is not penetrative sex in this part. So that is what the sensate focus is basically about. And as you have given the description, it typically begins with a non-sexual gentle touch. Partners take turns exploring each other's bodies, focusing on sensation rather than sexual performance or gratification. This is what we were talking about. So this is how the sensate focus goes on. Once this has been done, then then gradually just from normal touching, then it progresses to a sexual kind of a touch gradually. But the ultimate aim in this particular mode is not to make them perform the penetrative form at all. That will come much later. This is just you're getting acquainted with the body and feeling comfortable about the entire thing. This is what this sensate focus is about. After that comes the CBT. That is the cognitive behavior therapy. This is a more aggressive form for after the sensate focus. It focuses on altering thoughts and behaviors that distract. So the other distractions are taken out, the inhibitions are taken out, and the patient is made to feel comfortable. So the therapy serves to change the sexual behavior by focusing on the pleasure aspect of it. And the previous avoidance of sexual activity is actually replaced by being more comfortable about the entire process. And it is the limiting factor is that it is very time, it takes up a lot of time. So we have to, when we are dealing with it, we have to, we have to devote that kind of time. So a person who is dealing with this, we can do it ourselves. If we train, then we can do it ourselves, but we have to be, certain that yes, we will be able to devote that kind of time and patience. Otherwise, we can send them over to a therapist.
Yeah. So anybody, any other panelists want to add anything about the psychotherapy or any input for about psychotherapy?
And one more type will be mindfulness. That is also a part of the CBT. So these are usually dealt with by the therapist. But if we are that much interested in these topics, then we can train ourselves and handle them ourselves. Otherwise, we send them over to a therapist.
Even if we are not handling them ourselves, if we are aware of what these therapies are, what is mindfulness, what is cognitive therapy, then when the patient comes to us for follow-up, we can always ask her the progress about what the therapy is helping her and how the therapy is helping her.
There is also a fear model. So, the psychotherapists usually work on the fear model because so many times it is only the fear in certain women. So working on that aspect also helps.
Yes, the negative part is they try to take it out. That is what we were saying. Feeling more comfortable about the inhibitions and the fear, whatever. Inhibition can be fear also. If inhibition can be something else, but whatever those inhibitions are, the focus is to take those out to make it more, being more comfortable with it.
In fact, Dr. Queen, many of these women have had a childhood abuse. So very important, you have to always ask about their childhood abuse because they always have this trauma which unconsciously comes in the sexual activity. So it is very important to find out about this in their history.
But I also think that lack of sexual education is also one of the very important factors.
Yeah.
Even we can give like specific behavior therapy also, like guided images, or we can ask them self images and covered emotive images, touch.
Yes.
I'd also like to add that, I mean, Neeraj sir as co-convener.
Yes. Yes,
I'd
sir. You
also
are.
like to add, yeah, that we must ask for a history of alcohol or substance abuse in the male partner, because that may point out to some form of marital abuse that the female partner will probably never come out with.
I
Yes.
think, Dr. Dhaval, you're exactly right with what you're saying. So domestic abuse is also important.
So, Dr. Dhaval, I suppose this will come a little earlier when we're doing the history, and after that, when we're going into the counseling part of it, because that will be there. Where once we are into the this thing, CBT or mindfulness or sensate focus, one step before that, we should be dealing with this already.
Even before counseling, we have to ask like what they are thinking in bedroom, because so many times female are having so many thoughts outside of the bedroom thoughts, and because of that they are having this female sexual dysfunction.
That is basically mindfulness.
Yeah,
Training
Neeraj
of,
sir. Neeraj
yeah.
sir, one point we often are seeing patients, mostly this is regarding male patients regarding excessive porn addiction. Now,
Yes.
this is like the elephant in the room. It's like something no one wants to talk about. But there are married men who are actually not having sex with their wife, but are consuming porn regularly. Now,
Yes.
consuming porn to the extent that they are not able to achieve arousal or erection without watching porn, so that the wife of this is actually confused and wondering what went wrong because the man is watching porn discreetly. So we get patients for infertility. We go deep into the history. The semen analysis is normal. The periods are regular. Hormones are okay. It's basically an unexplained case of infertility. But actually, the main reason is there's no sexual activity. So for these male patients who have excessive porn consumption, I mean, we would rather counsel the patient, ask them to go off porn, refer them to a psychiatrist. What more can we do for this?
Yeah, basically it is like a de-addiction. We also have to refer them to psychologists who will help them to de-addict about the porn addiction.
Yeah. And
We
also
protect-
there are couples now, both are working with different time schedule. Like I've seen couples where the man is working in the daytime and the woman is a call center working in the night. So I think all this discrepancy in the time also, they lose interest.
Yeah,
Yeah.
that everything we cover in the counseling part. All what is the actual problem is then and how we can help them. That is actually counseling part. Yes, Poonam. Let's move to the next question, Dr. Poonam.
Yes, sir. So, Dr. Madhukiran, now we are coming up to the pharmacotherapy. We have just cleared everything. And what kind of, like, how you will go ahead with the pharmacotherapy?
So, ma'am, actually, as we have been discussing along, the main cause of female sexual dysfunction is the psychological part. So, there is a concept of sexual tipping point where a female is always having some inhibitory input, some excitatory inputs, and she's always having to balance in between these two. And there are certain chemicals which are responsible for these two parts. And most of the medicines that we use in these problems will either be increasing the positive inputs or decreasing the negative inputs. Like what we are using is flibanserin or bremelanotide. These flibanserin and buspirone are basically the serotonin uptake inhibitors, agonist or antagonist, which increase the serotonin A1 receptors. So there is more of positive input and less of the negative input of the serotonin. We have bremelanotide, which increases the melanocortin levels of the brain, and this is available here as Vyleesi, and it has to be used about 45 minutes before the act has to be done, because increased melanocortin will cause the excitatory phase more. Then we have the testosterone, which we are giving as patches or gel form. Again, this is a form. Testosterone is known to increase the sexual drive, but we have to understand that this particular medicine is important only in perimenopausal females, where the sexual urge is less. It's not very helpful for the younger patients. Then we have buspirone. As I said, it's a partial agonist and antagonist. Again, it increases the serotonin levels, the positive serotonin levels, which are mood elevating part. Then we have DHEA, as we have
seen that lower DHEA levels are causing hypoactive desire in the females. So adding 100 milligram DHEA daily for these patients will help them in having more of positive input in their, let's say, the STP formula. And then we have sildenafil or PHE inhibitors. Again, this medicine is also something we all know this causes vasocongestion. And this medicine is also important only in perimenopausal females where it seems to work. Otherwise, this is also not working in normal younger females. For younger females, more of the serotonin agonist antagonist like filbanserin and bisphenol are working because it is more to increase the positive mood, decrease the anxiety. So these are the medicines that we commonly use in these patients to help to come over their inhibitory problems.
Perfect, perfect. Any other panelists want to add anything about the pharmacotherapy part? Want to? So
I think, sir, in the menopausal women, mostly in the perimenopause and the genitourinary syndrome of menopause has to be looked into.
Yeah,
So
that we will cover in the last part.
Okay, okay.
Yes, and we are covering.
Sir, in perimenopausal or postmenopausal women, Tibolone also works quite well.
Yeah.
These are all for GSM actually. We are talking about interest and arousal problems.
Okay.
Tibolone generally will give post-menopausally after 1 year.
Yeah, so postmenopausal, a lot of people are using this. People who are specifically treating sexual problems, many of them are using because FSID often is secondary to that also, no? So it can
Yes,
be
ma'am.
secondary to the
Post-menopausal symptoms and sexual problems come.
So let's come to the second dysfunction, that is the female orgasmic dysfunction. So when sex is not enjoyable, it can become a core instead of satisfying intimate experience by both partner. Sexual desire may decline and sex may occur less often, and this can create resentment and conflict in the relationship. So orgasm was basically derived from the Greek word orgasmos, that is means excitement or swelling, and in common language it is also known as a climax. So Dr. Siddesh, can you tell us? Yeah. What is the female orgasmic disorder? What do you mean?
So basically, female orgasm is something that is the end of the sexual cycle that we have discussed. So when the cycle has started, it should ideally end in an orgasm. So there could be different issues related to an orgasm. It could be, say, frequency. So the orgasm has occurred, but then it has reduced frequency, or there is no orgasm happening, anorgasmia. Or there could be decreased intensity. So what she felt at one particular point of time, now she's not feeling suddenly. So that is decreased intensity. Timing. So sometimes it may happen that it is happening very early, that it is almost done and the female is no more interested. Or it is happening too late that the partner is done and the female is not orgasm. So one partner is left dissatisfied. Or it could be just decrease in the level of pleasure that the female feels. So, and all in all, this has to be there for at least 6 months to call it a disorder. If anything, like once or twice, then it may not be labeled as a disorder.
Yeah. It's common for all sexual dysfunction. It should be present at least for the 6 months, and it should be distress to the patient or couple. So anything related to frequency, intensity, timing, or pressure related to orgasm, then it is a orgasmic dysfunction. Poonam?
So, Dr. Vidya, that means what are the types of female orgasmic disorders? So, would you
just
please,
as just as
enumerate?
Siddesh said that, female the orgasm not being of good intensity, and also it is classified as a female sexual dysfunction by the DMS. And there are classification which depends. It could be primary or it could be secondary. Primary, where the woman has never experienced an orgasm under any circumstances, even by self-masturbation, she has not been able to achieve. Whereas acquired or secondary is when a woman previously had experienced but now has difficulty in achieving. Then there is the situational, where there is a generalized issue with her where she is not able to achieve orgasm in any situation, whether it is herself solo or by a partner. and in situational where she's able to achieve her orgasm, but only in specific contests. Like sometimes only during masturbation she's able to achieve orgasm, but during her intercourse she's not able to.
Perfect.
Again, it depends on the causes. It could be psychological, where there could be anxiety, depression, or she's had a past trauma. Or it could be also when, when a person has a lot of body imaging, shaming about themselves, or if there is a taboo about sex, where she's having a guilt of having sex. Or it could be anything related to hormonal, neurological, where she has a comorbid condition like spinal cord injuries, or she's on medication on antidepressants, or if she has anything to do with her partner, where she has interpersonal discordancy with her partner. These all can contribute and attribute to her orgasmic problems.
Perfect. So, Dr. Parul, you are there. How will you evaluate if person come with the orgasmic problem? Parul, you are there.
Parul, I don't think she's not visible.
So anyone can take up
Whosoever.
evaluation part. Madhu, you would like to take evaluation part? Dr. Madhu, she is there.
I think, sir, yeah, sir, I think just as any female sexual dysfunction history is taken, the evaluation goes in the same pattern where you actually have a complete sexual history from both. And as I said, first the female partner has to be evaluated, has to be confronted. And then when she's comfortable, we get in the partner, and then there is a partner history taking. Second is always the physical aspect of it, where as Dr. Queen said, that we have to focus on all her, self-focus, innate focus. So physical examination, and as Dr. Siddesh also said that, even as a partner, a lot of the male partners have issues because of the female partner.
Secondary.
So persistence of issues can lead to partner issues. Again, lab investigation remains the same as we discussed. And then depending on whether she really has a psychological aspect, we should then counsel either her alone or a partner counseling. So depending on everything, and I think a sexual response cycle where it starts from desire to arousal to orgasm, every stage has to be pointed out. So when there is screening, we need to know at what point, because sometimes they have desire, they have the arousal, but they don't have orgasm. So that is something we need to deal separately. Whereas sometimes they have all the three components, but they have a very painful sexual activity. So every response, every stage has to be evaluated separately. So this one thing which goes with the history, again, as I said, it comes to the same thing where we evaluate in the same format for a sexual dysfunction.
Even in history, actually every woman's body respond differently. So every woman has a different kind of nature, like how they want to be stimulated. So that history also in personally we have to ask, because every woman has different
I think very important, Dr. Naisarga, what you said is the foreplay, just before the sexual stimulation act, what you said could be different in different patients with
Yes,
female.
ma'am.
So you have to know whether these cycles are helping her, not helping her. And that is very important to get it from the patient herself.
And we have to ask her like how she wants. So we can ask and we can counsel other partner actually.
Yeah, very important, very important. So I think history is the main point in our evaluation.
Communication with each partner, that is very important.
She should be
And
told
I think,
that.
I think we need to also know her history in the bedroom. Like, whether she and her partner actually communicate. Do they have open communication with regard to the distress that she's going through? Because sometimes what happens, the partner is disinterested, and that can give more agony to the patient. So this part also needs to be evaluated, whether she's comfortable with her partner, whether he's he's being helpful in understanding her issue.
Very nice.
I think I would like to add one thing.
Yes, Asif.
This one word is missing, love, L-O-V-E.
Yeah, love, of course.
That's very
Of course,
important.
Of course.
That deals the emotional, psychotherapy, everything.
Absolutely.
If that
How
is
cozy they
there,
are with
I
each
think
other.
all these factors, what we are discussing, may not exist on.
So you truly said right that if there is no love between partner, that is the discordancy between the partner. Then having all this counseling has no meaning. So we need to understand from the female about her relation with her partner. So that's very important. And then, of course, in the therapeutic part, as we said, counseling works wonders. Again, whether individual or partner, I always believe that partner counseling helps because you open up the dialogue between the two. And then we support them. Sometimes sex therapy is very important because, as we all know, that there are innocent couples who have no idea about what sexual orgasm truly means. They probably have had sex to have babies, but they don't have any pleasure in that. So all
Actually,
these,
Dr. Aslisha, the fact is that love is too much over there. Two IITians were there. They were loving each other. They were spending very good time with each other, cuddling and spending time, cozy time. But they were not doing sex. There was no consummation. And they were saying that, yes, we are very happy with that. Do something, some ART, some IUI or something. We'll have a baby for us and for our, the family members, and we are very happy. We don't want sex. So there, the penetration, the penetrative sex itself needs to be there, and the role of this, like we as a gynecologist, we all have to be in that line. We have to create that awareness that yes, love is one thing, and the sex is another thing. In a married life, or these days, the couples are there, sexually active, and they are also having so many disturbances.
yes, sir.
They're changing partners. Yeah, every time. In 4 months, 5 months, the love is over. The life is
I think Dr.
the two
Poonam,
aspects are there.
yeah, you spoke very well,
Actually,
but
they
the
need
language of love
premarital
can be different.
counseling. Actually, everyone needs premarital counseling. Actually, it's not everywhere it's going on.
Premarital
Only there
sexual
are some states
education.
they are giving premarital counseling. We have to teach them anatomy also in premarital counseling
But
and what is the
Dr.
importance of
Naisargi,
sexual life.
I had exactly the way Dr. Poonam said, I had a similar case where the couple were very loving. But when it came to sexual contact, they just were not ready for it. And it was so difficult to, explain things to them because they said, we are very cordial with each other. We love each other. We can't do without each other. But their language of love was
We
very
salute
different.
Dr. Neeraj Jadhav, sir, because she had taken that initiative, and now every gynecologist is now talking about this sexual, education, sexuality education, and everything. So let's go ahead with the therapeutic options. And I think we have completed that. And now Dr. Vaidehi, so at the place of Dr. Vaidehi, Dr. Queen is there. So what is the direct masturbation technique? And like this is a part of therapeutic options. So is she there?
Yeah,
Dr.
I
Queen?
am there. I am there.
Yeah. Please go
So
ahead.
yeah, so like the directed, like it is in that direction only, taking masturbation into question. That is how we start with the orgasm, because we all know that clitoral stimulation in most of the cases gives the maximum possibility of the orgasm happening. Those who have an orgasmic problem, the maximum results we get is with clitoral stimulation rather than the penetrative forming.
They should be exposed to that sexual pleasure.
Yeah. So the first thing that is done is that we expose her or teach her to attain orgasm through masturbation. Yeah. In very few cases, we will fail in that regard, trying that way. So once she is acquainted with that, she now realizes the kind of pleasure she has achieved. Because someone who is for suppose it's she's a first timer, never has experienced any kind of orgasm with the masturbation technique alone, doing it alone, then she knows that what she has achieved. So then she gradually starts liking that format, and then that is with herself. Then gradually she will open up and she might do it with the partner. So with the partner might be doing it with stimulation either by the finger or the tongue or whichever way. So then first of all herself, then with the partner, and then gradually going into the penetrative part, and then making her accustomed to getting orgasm with the penetrative sex. So this is how that directed masturbation, it is done this way. Yeah.
Very
Here
nice.
I would like to add one thing.
So first she has to, and because clitoral stimulation hardly fails, in very few occasions we'll find that it fails. If it's done properly, it will not fail. And so with her getting the result, her confidence will also get boosted.
I think we
Here,
can
here
just
I would like to add one thing. That the orgasmic process is divided into two parts, clitoral and vaginal. And sometimes some patient may not feel orgasm on clitoral stimulation. And we have to understand as counselors that she might be that person who is not going to have it on clitoral, or she is not going to have on vaginal, so that we can counsel them further that this is the limit that we can go. Otherwise, unexpectedly, she might be thinking of that everyone is having, I'm not having, everyone is having on clitoral, I'm not having. So this is the differentiation that sometimes we also have to understand.
First of all, ma'am, we should always ask our patients to explore her own body, to explore her own areas of stimulation, which may be the breast, which may be the pinna, which may be the inner side of the thigh, followed by then clitoral stimulation. First of all,
Vandana, this is the sensate focus we were talking about. No?
Yes,
When you're
yes,
talking
ma'am,
about the
yes,
other
ma'am.
parts, we've already dealt with it. Now we're coming much further after all of that has been already done.
But
We've already
sometimes,
taken care of that.
But Dr.
female would
Vanna,
need,
Dr. Vanna, do
anyone
you
will
think,
get.
Yes.
Dr. Vanna, isn't it right that since childhood it is taught to our boy or girl that don't touch your genitalia? It's very bad thing, and that things
Yes, sir.
take into their mind.
Yeah.
We are not telling our kids, we are not telling in schools that you are supposed to touch your genitalia, and you are not supposed to let anybody else touch your genitalia and the
I think
private parts.
now that we teach our youngsters about good and bad touch, the bad touch involves all this. So it gets into their mind that this is bad, and that we have to open up.
In fact, we are teaching only the bad touch. We are not even telling about the good touch.
We don't tell them.
But ma'am, actually, we should initiate this awareness program for every school in every week so they can understand, even boys and girls. That prayas started by Neeraj sir and Anup sir. Like, so
Yeah, I
that
was
is
going to
very
say that
important. We have to teach.
yes, Dr. Neeraj has started this thing, yes.
No, that bad touch ka barrier has to break, Dr. Neeraj. So you'll have to work for that.
सारे पेरेंट्स आ जाएंगे कि आप बैड टच तो मना कर रहे हो, गुड टच भी सिखा रहे हो हमारे बच्चों को। बड़ा मुश्किल है। दिस इज द सेक्सुअलिटी एजुकेशन इन स्कूल्स। पेरेंट्स को पहले अवेयरनेस उनके अंदर करनी होगी, एंड देन वील, मतलब दिस इज अ डिफिकल्ट वे टू गो, बट यस।
Can anyone throw light on the medical devices available?
Medical devices.
Yeah. Anyone?
So we are having the sexual enhancement devices. These devices help assist the women in achieving an orgasm. Their vibrators are available. There are various air pulsating devices which are stimulating the clitoral, like clitoral devices are there, which create mild suction type at the area of clitoris, and that increases the blood flow, further leading to the orgasm, help in achieving the orgasm. And there we can have the next pic, and we can have the various vibrators which work with the bed. Yes. There are various vibrators available on the Amazon even, and there is a device. Eros is the clitoral device which helps with the help of a suction, increasing the blood flow towards the clitoris, and thereby it helps in achieving orgasm.
So there is nothing wrong in using device if patient is
There is
having.
nothing wrong. We should ask our patients.
If you prescribe this device, there is so many questions related to it.
You know,
Exactly,
sir,
so
many questions will be directed to us, sir. But if the women are distressed by the anorgasmia, there is nothing wrong in advising. If the patient is not achieving orgasm with the partner, then she can use the devices to satisfy herself.
I can just say one thing is a female does not need to have dysfunction, but you know, some of the female where the partner is bedridden for some issues and she's not been able to experience, we as gynecologists can help them in, you know, procuring these devices, because that helps them in the long run.
Exactly, and this is going to help them preventing all those sexually
All
transmitted
those,
diseases and other things.
yes,
Like these days, the adolescents are
yes.
moving into ART clinics. My friend had just come and was telling so many boys, adolescent boys are coming with, the straight ones, the other ones, and are suffering from different sexually transmitted diseases. So we should promote that in a different way, and see all these need a great awareness
I
abhiyan.
think it
है ना?
is the need of the
So,
hour with the generation that we are now in to be more open about things like this.
Let's move to next question. Yeah.
so we just
Controversial
want
part.
Dr. Parul come. Yes, this is the need of the time, and sexual medicine and cosmetic gynae, they both are intricately woven with each other. So we'll now moving towards that cosmetic gynae. Parul, where are you? Parul is not there. So who is going to take this? Dr.
Madhu
Vandana?
or Dr.
Oh, Dr.
Neetu is
Yes,
Madhu
there?
is there.
yes,
Yeah,
yes,
she's a
yes, yes.
cosmetic
I'll
gynecologist.
take, I'll take, I'll
Yeah.
take.
So
So,
just tell us
the
about these shots.
So basically, what we are looking for in the cosmetic gynae related to orgasmic disorder is to enhance the different orgasmic points on the perineal body of the patient. So there are the G shot is the most common, most known shot where we inject either fillers or PRP prepared at the G point. And if you actually initially it was a very controversial thing whether deep spot exists or not, but we now know that it is there. And this spot can be actually elicited when we inject. We actually elicit in the interior vaginal wall, and you can stroke the area and you can feel that G spot arousal and congestion at the point. So if in these females we can give a shot in these places, G shots and O shots, there are P shots and A shots also. Basically these areas where uh, they are near the perineal area, where during friction there is increased arousal and congestion. So we give these fillers and PRPs at these points to enhance the sexual pleasure of the female.
Perfect.
And me and Dr. Vidya Pancholia have come up with Rati shot. So very soon, this is going to be patented. So very
Will
soon
it
we
be
will be
different
coming
from
up
the
with
O
that.
shot, ma'am, like the what we are doing
Yes,
with the
Charles Runnels. Yeah. Mhm.
yeah.
So O
Okay.
shot is patented by Charles Runnels. So we should say orgasmic shots completely. It should not be written over there in your clinics. And we have also come up with another method, and very soon we'll be discussing Rati shot.
So, Dr. Vandana, can you tell us about is there any role of pharmacotherapy when there is an orgasmic problem?
Sir, if the orgasmic problems are they are not managed with the help of psychological therapy or all the devices, then the medical therapy we can start. It is very definitely challenging because USFDA has not approved many of the drugs, but many of the clinical trials have been done, and various research articles also have been published regarding sildenafil, the phosphodiesterase 5 inhibitor that increases lubrication and further helps the women in achieving the orgasm. So sildenafil is one of the most commonly used drug. In the perimenopausal and the postmenopausal females, the estrogen giving hormone replacement therapy, even tibolone, as we already discussed, tibolone always helps in the postmenopausal females. And testosterone patches, DHEA also helps. The combined HRT in the form of combined estrogen and testosterone we can give for achieving the orgasm. Various nutraceuticals like yohimbine has also been tried, and adding the vitamins and antioxidants always a help. Yohimbine also has been used in many research articles, and always has positive response in achieving the orgasm. But the most commonly drug definitely remains the sildenafil, and it is yet not approved by USFDA, but we are using it, and we are achieving it is very useful in achieving the orgasm.
Perfect.
Are there any local preparation also just to apply?
Nitriate.
A local application we can have the testosterone patches. Also, testosterone gel is also available, but results are not so good. we can have that testosterone patches and gel.
Yeah.
In cases of dyspareunia, if there's that we can use some lubricants.
Yeah, that we will discuss in that part.
Yes.
So now let's move to the third dysfunction, that is a vaginismus. Poonam?
Yeah, so Dr. Vidya,
Yeah.
what is vaginismus? What exactly is vaginismus?
So again, as we look at vaginismus, it is a part of the female sexual dysfunction. Again, it involves where the pelvic floor dysfunction here. So it is a condition where a woman experiences involuntary spasms around her vagina, making penetration, which could be anything from her finger penetration or tampons or even intercourse, very painful. In fact, it was impossible in certain patients, and it comes under the classification of the genitopelvic pain, which is the penetrative disorder dysfunction in the DSM criteria. Now, what are the types are? There could be primary or secondary again. Primary, where we are looking at that even in the first attempt, where she's probably tried to use a tampon, a simple tampon, she could not even attempt that, or the first intercourse was not possible. So it is usually related to her fear most often, or any misinformation regarding the same, or if she's psychologically having the fear in her. The secondary, where she's had, good sexual intercourse before, but she develops it over a period of time. And usually the triggers are normally in the postpartum period, where she's had, a very bad tear and the scar is thick and not healed well, or in cases of any trauma or infection or any other comorbid condition where secondarily she has this vaginismus. And again, situational vaginismus could be globally, where she finds pain everywhere around, whenever the point of penetration comes, she finds painful episodes. And in certain cases, she is able to put in the tampon, but she is not able to have intercourse. So these all come in the criteria
So
of
it has got two, variables, the mental one and the psychological one and the local one, pathological one. And the real vaginismus is something, the real vaginismus is the contracture of perivaginal muscles, where the female is actually ready to go for the cozy relationship, for getting conjugated, but she's not able to because of the contracture, involuntary
yeah, it's so
contracture. So the
involuntary that she's
mental
not
part,
able to
psychological
control and
part.
relax herself.
Yeah,
Yeah.
exactly. So we'll move
So-
ahead and yes, sir.
Dr. Vandana, can you tell us about what are the different types and gradings of vaginismus? Because
Yes,
it's
sir.
I
important
think
to
types has
the
been,
there is a
she has
class
taken, the grading is noted. Yeah.
types has
grading.
been taken. I will tell about the grades. It is
Yes.
according to Lemont's classification, and the grades are increasing with the increase in severity of the symptoms. Like the grade 1 is the mildest form, in which there is spasm of the levator ani, but with the reassurance, the patient is able to relax, and we can have a gynecological examination. In grade 2, their patient is unable to relax even out of after the reassurance, but definitely we can do an examination. But spasm of levator ani persists in this. Grade 3, even the patient does not allow the examination by elevating her buttocks. Grade 4, further severity is increasing. She will elevate her buttocks, she will retract herself, she'll adduct her thighs, she will jump actually, leading to dorsal arcing to avoid being examined. And in grade 5, all these panic, along with elevation of the buttocks, retraction and erection of the thighs, there is visceral responses are added to the grade 5. Like she may start crying, she may start shaking, she may have a hypotensive episode, she will tremble herself,
Hysteric behavior.
start
Yes.
sweating. We will think that she has a psychological panic attack. So that is included in the grade 5. And all these are the grade 5. grades of
PASIC
vaginismus.
added this number 5, and that is why it is a Lamont's and PASIC classification. So, Dr. Madhukiran, so how are you going to evaluate a vaginismus patient?
So as we
She's
have
not.
already been discussing
Yeah,
that the effect of vaginismus are two parts, the psychological part and the physical part, and some stage somehow these two come together to produce that effect of physical contractures because of the psychological stimulation for sex. And how it comes, maybe because of the religious beliefs that the family is holding, the teachings that she is having, the past physical relations, traumatic relations, present traumatic relations. So she does not know. She has a sense of fear for what might be coming, and then this thing combines with what should I say? It becomes a reflex which is not under her control. So we have to take proper history about the origin of vaginismus, from where it is coming from. Is it coming from her childhood? Is it coming from her beliefs? Is it coming from her traumatic past? Is it coming from her present interpersonal relationship, or maybe there may be some neurological and orthopedic causes also for this thing. And why this is important to understand, because as we will be later discussing, that mindfulness is one method which is very helpful in vaginismus, because of this reason only, when we can dissociate her psychological and physical problem by making her understand that these are two different parts. So we have to take a detailed history of all the contributing factors.
So coming to the management of vaginismus, first we have to assure that the treatment options are available. We have to address the medical condition of patient as well as couple. Sexual education and counseling is important in all dysfunction. Then the gold standard is the systemic vaginal desensitization. We need in some of the patient anxiolytic. Then there are various psychotherapy like biofeedback, physical therapy with or without biofeedback, hypnotherapy, psychotherapy, cognitive behavioral therapy, sex therapy, and recently there is a use of Botox in the management of vaginismus. So,
Neeraj sir, sorry to interrupt, but we
yes,
are running short of time. So
yes.
what talks after this?
Before desensitization, sir, we have to take a consent and we have to explain them. Like, we are not injecting anything in your part. First, we are explaining you everything. So in that, we have to teach them first fingering, then double fingering. From first patient, how to enter finger, then with partner, then twisting of the finger, then gradually dilators and Foley's catheter with 5 ml, then 10 ml, 15 ml. Gradually, we have to teach them like weekly, and we have to explain them. This will take bit time for 3 months. It's 12 weeks time, but gradually you will improve. And every week we have to assess them.
Yeah. So, who is telling about the Botox therapy, role of Botox therapy? Can
Botulinum toxin.
Yeah. Who is like to take that? Dr. Madhu, you can tell about Botox therapy.
Okay, as discussed earlier also, that this is an involuntary, it is, we have to understand that it is an involuntary contracture of the pelvic muscles. So what we are doing by injecting Botox will stop the contraction of these pelvic muscles. And what we usually use is around 50 to 100 in an average patient, because the muscles are very thick. We usually use 100 units, and you reconstitute the Botox. Patient is under sedation. Please understand, this cannot be done in a patient who is awake. And a very simple method is, when you are using Cuscos, the 4 and 6 o'clock positions are the best, so that you avoid injuring the urethra and the rectum. Palpate the pelvic muscle, and you give in 2 or 3 locations this bolus of Botox. Once you are giving that Botox, it will quiescent the muscle. Even if the patient wants to contract, it is not going to contract. And then we can gradually introduce vaginal dilators for these patients. And once that connection is broken, that reflex is broken, usually single injection is sufficient in vaginismus patients, and they usually are well treated by this treatment. So now it is very common.
Perfect.
Yes.
So let's move to the last part, that is GSM. So, yes, Poonam.
So we would like to have from Dr. Siddesh some insights for moisturizers and lubricants. Are you there?
I think we are late for the
Siddesh is
emergency.
not there.
We are late for
So,
Yeah, Siddesh is not there here to rush for a call.
Yeah, he has an emergency or something.
Anyone can,
okay.
because we are routinely
Can you-
using moisturizer lubricants, so we all are aware of this.
Yeah, we all are using it.
Yeah.
And
Nisargi, you can take it.
I think genito urinary.
Moisturizers
Yes, Dr.
can...
Vidya.
No, carry on. Somebody started.
No, ma'am, please, ma'am.
No, I think we all know that the
Jaldi se lo bhai question.
yeah, ectopic
Because we
changes
are running short of time.
ectopic changes are progressive in GSM. So it's very important that the moisturizer effect, which has the ability to retain the water retention, and then it helps in hydration. So it mimics the vaginal secretion, and that makes the patient less painful when she has intercourse. So it has a long lasting effect. Of course, lubricants act has very similar effect, very specifically designed again to reduce the friction during the coitus. So this is very important for a GSM patient. Again, local estrogen therapy, I think we all know about this. Let's not discuss more. We know that there are tablet forms, there are creams. We have the Premarin, we have the Avalon, which we normally give all our GSM patients who have ectopic changes, leave alone.
Beautiful sprays are also there these days.
There are sprays and even patches now are available. So these all help in the changes in the genitourinary syndrome and especially the genital organs. The role of
it is for your role of Tigulon.
So we all know that Tigulon is a synthetic steroid and it has both estrogenic and androgenic and progesterone, all three actions put together, and it has its effect on the bone, and it does not have its effect on other like the breast, and also it is very freely given without any major adverse effects.
So what, sir?
Yes,
and it works very well on the vasomotor system also, sir. I've seen a lot of people who have hot flashes. They do very well with Tubulon. So but
Tubulon is a
sexual dysfunction. I mean, it helps in those, but it also helps in the VMS.
Yes, madam.
So Dr. Vandana, please come and just take this question. What is the role of SOM? Selective estrogen receptor modulators. Nasargi, you can take if Dr. Vandana is not
non-steroidal agents. Osmaniferum, it's selective estrogen receptor modulators, and they are synthetic non-steroidal agents that exerts variable agonist and antagonist property and on the estrogenic receptor of the target tissue. It will be given by 60 mg daily orally, and it's proposed to those women who are not eligible for vaginal estrogen therapy. And it has a positive effect on vaginal epithelium and minimal effect on endometrial tissue. So it's very useful.
Very nice.
Yes, Dr. Poonam, you can go ahead with the cosmetic
So
part.
currently, for genital rejuvenation, we are having so many assets for us. So energy-based devices, we are not going to give much time for these, but yes, lasers, HIFU, that is ultrasound therapy, high intensity focused ultrasound, and electromagnetic chairs are there to take care of the the sexual dysfunctions. And there are minimally invasive therapies, which are PRP in the form of PRP. Sir, I think I should go ahead
yes. Just little
fast with this. And
Yeah.
fillers, hyaluronic acid fillers, pre-filled syringes are available in the market, and they are just volumizing agents. Botox, we have talked about. These are causing the temporary paralysis of the muscles. Carboxytherapy is there, which is carbon dioxide therapy, which is when given the oxygen is actually deloaded in the targeted tissue. So we are applying we are giving carbon dioxide, and the tissue gets automatically oxygen more in that area. And mesotherapy and threads are just amazing things, but actually it needs a separate session, a prolonged session. Surgical interventions are also there, where we are doing some functional reductions of labia minora, reshaping of labia minora, clitoral hood reduction. Yes, because this clitoral hood is just completely covering the clitoris, which is the most sensitive organ in a female. So we are just dehooding the clitoris. Labia majora, if it is redundant and patient is not feeling confident, we are just volumizing these labia majora and just augmenting this. Mons plasty can be done. Many females are having sagging mons, protuberant mons. So there we can do some plastic surgery. We can take help of our plastic surgeon friend. Colporrhaphy and perineorrhaphy is the part which we gynecologists have always been doing, and we are just satisfying our patients with the vaginoplasties and perineoplasties. So these are the things which are taking care of all the sexual problems, especially around the perimenopausal ages. And so
right now, I think we are running short of time, so we will not go in details
yeah,
of
so
the
we should
about
skip
right.
all these.
Yeah.
Yes, sir.
So thank you very much. All the panelists were fantastic with their superb inputs and the discussion. And thank you to my co-moderator, Dr. Poonam, for wonderfully moderating this panel.
Thank you,
Thank you,
Neeraj
sir.
sir.
Thank you for making me a part of
Thank you
this.
for involving us
Thank
in
you,
this.
sir. Thank you,
Thank you
Poonam.
very much, sir. Thank you, everybody.
Thank you, dear moderators and panelists, for a panel that could have gone on and a topic that doesn't seem to end. But for paucity of time, we'll have to now move on to our next session. Our next session, we have a talk on sexuality in pregnancy. I would like to invite our chairpersons for the same. And we have Dr. Ankesh Sahitya CV.
Hello.
Yeah, hello, good evening, everybody. I've been around from the start, only just waiting for the sessions to start.
That's very kind of you, Ankesh. I would also like to invite our next chairperson, Dr. Sargam Soni. Sargam is a managing committee member of the AFG, a TEDx speaker, and a member of the Foxy Infertility Committee for the years 2024 to 26. Welcome, Sargam.
I was very happy to see. I was very happy to see
Introduce
Sargam's
the speaker.
camera getting on. Sarvan, can you put on your camera again? Very nice. You're working so hard, in the evening over here, getting your head, and we are looking forward to seeing you tomorrow for the IUI and Isoscopy workshop. So, I just wanted to say I've been following this webinar from 6 p.m. and it's been so good. Everyone speaking so passionately that this is showing how genuine the issue is of the sexual dysfunction. Now, actually speaking, we are all gynecologists, but everyone over here is encountering patients having issues of sexual dysfunction. May it be porn addiction, may it be adultery, intimacy issues, libido differentiation, many things are going on as far as infertility, but actually there are hidden issues of sexual dysfunction. On that note, I want to invite today's speaker for our session, Dr. Queen Aditya. She's a consultant OBGYN at Calcutta, currently East Zone Coordinator in Foxy Ethics and Medical Legal Committee, East Zone Coordinator Foxy Sexual Medicine Committee, and an executive member of the IMA branch in Kolkata. Welcome, madam. We are looking forward to your talk on sexuality during pregnancy.
Thank you so much. Thank you, Ankesh, and thank you, Sargam. Thank you so much. And Neeraj sir, thank you so much for having me here today, and thanking Nitin and Bela for giving us this platform. And so can I share my screen?
Yes, madam. We are looking forward, madam.
Yeah. I have to be given the option. Trying, let me see. Give me a second. So is the screen visible? Oh, yeah. Screen is visible. I'll try to make it full screen. Just give me a second. Just give me, I'm trying to make it full screen. Yeah. Can you see it? Is the screen visible?
Perfect.
Yeah, okay. So, talking about sex and sexuality in pregnancy. And thank you so much once again to dear Neeraj sir for giving me this opportunity today. And without wasting any time, let's get into the root of the whole matter. So a woman's sexual function is a complex interplay of physical, emotional, and psychological factors between the couple or the partners, as we all understand. Pregnancy is a very, very natural and sought after phase in a woman's life. And pregnancy and sexuality, both are natural instincts actually, and natural normal parts of a woman's life. It's not a disease, it's not something imaginary, it's not something supernatural. It's both are very natural parts of her existence, and to be a mother is a natural instinct to almost every woman. Both pregnancy and sexuality, as I already mentioned, are very normal and natural, and they are inherent to a woman's being, like her existence. They are very inherent. So pregnancy or childbirth is not a disease, as we all understand, being obstetricians, a very, very natural part of a woman's life. The couple need not be denied of sexual pleasure and happiness when pregnancy is devoid of any complications. So in a pregnancy, there are no complications or high risk factors. The very fact that the woman walks into our chamber and announces that I've missed my cycle, and then the test comes positive. And the first thing that I know, and I'm sure all of you have come across many obstetricians saying that, okay, now you are pregnant. So when they ask, either they ask or from ourselves, many doctors I've seen, they offer this information that you better, abstain. So this is a very common part of, a woman's life in this phase, that either the family or the doctor, when the doctors ask, should I abstain? Yes, you better abstain. If the doctor, even if the doctor does not offer this information, when asked, if very, uncomfortably, finally they bring out the question, many doctors I've come across, because when a patient comes to me for a second opinion or something else, my previous doctor had told me to abstain. So this, I have very frequently come across this, and I'm sure many of you in your practice have also come across the same. But by and large, when the pregnancy is not complicated, or there are not high risk factors like recurrent pregnancy loss, or these kind of things like incompetent cervix, and those kind, apart from those, in a regular normal pregnancy, they should not be denied, the pleasure of engaging in this kind of activity. Sexual relationship is part of the quality of life, as we were talking about what is sexual health in the previous prolonged discussion. What is sexual health? What is dysfunction? There we were speaking about the quality of life. So a proper sexual relationship is required for a proper quality of life, and we have no right to deny them this this aspect of their lives unless there is a specific reason. So the woman and the couple will have plenty of questions regarding sexual activity during pregnancy, and we have to know what to say. As I already told you, I have come across several doctors who tell them, once they're asked, the doctor says, no, it's better you abstain, without knowing head or tail of the matter directly, so that they don't get it. Suppose something goes wrong, there is a miscarriage or something, they don't get blamed. So that is why they directly say that, no, it's better you abstain. So instead of doing that, we have to know, the details of what we can actually tell our patients. And being trained under Dr. Neeraj, somebody's, this thing is on, kindly, if they can mute themselves, or if the, organizers, if they can mute the other people, it's causing disturbance. Okay, so being trained under Dr. Neeraj, so now many of us know exactly what to tell our patients. So why I said this is that many of our fraternity, they actually tell the patients to, stay away from physical intimacy. That is why this question is actually coming up. So the patients, they feel shy and are hesitant to discuss the issue with their doctors in many cases. If they do ask, as I already told you, I found out many doctors saying it's better that you keep away from this kind of physical intimacy. So doctors also think that it is not an issue to discuss, but sometimes when they are confronted with the question, they actually give a negative this thing, that it's better you stay away. So we must change our attitude in this regard. Changes in sexuality can be significant during pregnancy and in the postpartum period, unless the physicians themselves are familiar with the scientific data. And the potential for providing patients with misleading or incorrect information is great, which I already gave you an example about. Now, patients may rely on anecdotes, old wives' tales, or other sources which are not true. When the woman conceives and welcomes the new bundle of joy, the whole family will be preparing to welcome the same. And in most of the cases, the elders of the family, especially the woman folk, will give them, all kinds of tips regarding the other aspects, like you sleep this way, eat this, do not eat this. In most of the cases, they say do not eat papaya, pineapple, this, all this kind of nonsense is usually passed on, this kind of information. And wear loose clothes, do not travel too much, avoid jerky journeys. These things are, this kind of tips are given to the woman by the elderly people in the family, or suppose an elder sister or a cousin or aunt, somebody. But nobody actually, everyone keeps mum as far as the sexuality part is concerned. So as I mentioned, the only advice she did not receive is about whether to continue with her sexual practices or not, and if to continue, then how it is safe, which time it is safe. So these kind of issues nobody talks about, and many of the doctors, because of lack of knowledge, directly say it is better that you abstain in this during the period of pregnancy, and then you start again after delivery. This is what many delivery, that is maybe after lactation, that is what many doctors actually tell their patients, and I'm sure many of you have first-hand evidence of the same. So what happens is that during the pregnancy, many people are asked, women are asked to abstain, but it is not required. In the first initial part, that is in the first trimester, many women feel uncomfortable, and so it might, and the desire might also be low, that is there. But and in the last part also, but in the second trimester, most women feel quite comfortable, and they actually themselves also want to engage. Now, after delivery, a woman often stays at her mother's place for 6 months or so, especially in this country, and therefore there is a self-imposed abstinence during that time. If she is at her mother's place, away from the spouse or the partner, then obviously there is abstinence. The side effects of this prolonged abstinence, as I mentioned, in the first trimester, last trimester, very few women actually engage, if at all, then in the second trimester, and many are told by the relatives or by the doctor to abstain throughout. And so 9 months plus another 6 to 12 months, so it's a long period, and this can really cause a lot of interpersonal disturbances in the couple. And in so many cases, the frustrated husband actually seeks pleasure or sexual satisfaction outside, and this will give rise to an extramarital relationship where there was no need for the same. It is only because the person is totally deprived of any kind of physical intimacy during that period that these kind of things actually crop up. Sexual behavior depends on several factors, including age, culture, relationship, the physical changes of pregnancy, discomfort, fear of fetal harm. This is a very, very important issue. Many women themselves feel that if they are engaging in any kind of activity, intimacy, physical intimacy, then that can harm the baby in utero. And that is why they, shoo away the partner. So and moreover, as we were talking about, one, like in a relationship, dysfunction of one is giving rise to secondarily dysfunction in the other. So similarly, these kind of factors can also play a role. During pregnancy, there are various hormones which have an effect on physical and mental changes that we all know, and that can have a bearing on the sexual functioning. Progesterone is responsible for physical and mental changes. Estrogen can affect sexual desire and function. Oxytocin, as we all know, the love hormone, releases during orgasm, and it can cause uterine contractions. Prolactin increased level, which usually happens, we come across it, that affects the sexual desire, and it usually reduces the desire. I think Ankesh had already mentioned prolactin right at the beginning. It usually dampens desire to a great extent, and because prolactin levels we all come across, it increases during pregnancy, and so there can be a dampened effect as far as the desire is concerned. Coming to the psychological changes, there is in many cases a decrease in self-esteem because of the changing body structure, the body image. There's a negative body image. There is anxiety, fear, which I've already mentioned. In many cases, in fear of harming the unborn child. Some women, because of the growing belly, they perceive a loss of attractiveness. They feel that I'm not as attractive as I used to be. And in many cultural, like in our country, as many mothers or elders, they tell or advise them to abstain. So all of these facts are there, and myths about the various practices also play a role, and the interpersonal relationship, as I already mentioned. Physical aspects of sexuality in pregnancy, the first trimester, as we all know, the nausea, vomiting, urinary frequency, urgency, all of these things, the breast changes, the pricking sensation, the changes in the genital, excessive blood flow, the enhanced blood flow, secretions, abdominal girth increasing, all of this can cause discomfort and can have a bearing on normal sexual activity. Every couple has several questions, and so when they come to us, we have to know what to answer. And because of the taboos attached to this kind of physical intimacy, many couples do not throw the question to the doctor. They just keep mum, and many of us will, even in today's world, we also do not ask anything about it, and the question of this physical intimacy is not even brought up either by the patient or by the doctor. And if the patient overcomes the inhibition and comes up with the question, in many cases, as I already told you, we have found out that the doctor says it's better that you keep away during the pregnancy and a few months after it. But it's high time, and especially after Dr. Neeraj has brought the subject of sexual medicine into our community of doctors, of gynecologists, and all of us are now more or less trained in this regard. So it is high time that we take the initiative and help our patients as far as this issue is concerned. So the concerns are, is it safe during pregnancy? When is it not safe? Can it harm the baby? Can the orgasm cause an abortion or a uterine contraction? Is the sex drive increased or decreased during pregnancy? What is the man's view? And so on. Hence, doctors should be aware of the sexuality concerns during pregnancy to answer the queries of the couple. Most pregnant women can engage in sexual activity throughout pregnancy in the absence of complications or contraindications. The desire, libido, arousal, orgasm may vary during the 3 trimesters. Couples should keep some level of intimacy going on throughout the period of pregnancy. This helps them to keep the relationship healthy and to prevent eventual, marital disharmony or extramarital affairs or so on. Most researchers suggest that desire during the first trimester of pregnancy decreases, as I have already mentioned. And most of them indicate that it increases in the second trimester and gradually again reduces in the last trimester because of the growing belly, mostly. And also in fear that, any kind of activity might induce labor pain or something like that. Many women have that kind of a notion, and that is why the frequency has been found to reduce in the last trimester as well. Some women, however, report greater sexual satisfaction during this time period. Physical intimacy during pregnancy is a low-risk behavior, except only when it is a high-risk pregnancy or there is a BOH or there are contraindications. Psychological usefulness. Some research studies in the 80s and 90s indicate that overall sexual satisfaction was correlated with feeling happy about being pregnant, feeling more attractive in the later parts of pregnancy, and also experiencing orgasm. Natural prostaglandin content of the seminal fluid can favor the maturation process of cervix, making it more flexible and allowing easier dilatation and effacement of cervix, and therefore promoting the normal delivery rate. There is some evidence that exposure to the partner's semen can prevent PET due to the absorption of several immune modulating factors which are present in the seminal fluid. So there can be positive aspects to direct physical intimacy. So will it be difficult or different? So many report that sex feels different during pregnancy. Some find it more pleasurable. It varies from person to person and from trimester to trimester or at different moments, like suppose in the second month it was uncomfortable, there was discomfort, but 2 months later that same woman in that same pregnancy might be more comfortable. Also, so it can vary from different phases in the same pregnancy, and it can also vary from one woman to another. So some women find it more pleasurable, others find it less pleasurable. As for example, there is, we all know that there is enhanced blood supply to the genital organs. So that enhanced blood flow can in some cases increase the sensitivity, and so some women can feel more aroused or can enjoy it better, whereas that increase in blood flow in some women can cause pain. So it can vary from person to person and also in the same person at different times. So the increased blood flow to the pelvic area can cause engorgement of the genitals. So some kind of form of engorgement can increase the sensitivity, whereas certain further enhancement of that engorgement can cause pain also. So the heightened sensation that results may add to the pleasure during intimacy in some cases, and more vaginal discharge or moistness will also help. We understand because of increased vascularity, there can be more discharge, so the lubrication might improve, and that can also improve the situation in many cases. So as I mentioned, for some, the genital engorgement may give uncomfortable feeling of fullness, and that can give rise to some kind of pain as well. And so some women might, after attempting, might shy away from it, and henceforth might ask the partner to abstain. So that can also be there. That is a theoretical as well as practical possibility. There can be mild abdominal cramps due to uterine contractions after orgasm, as I've already mentioned. During the orgasm, there can be increased oxytocin release, which can give rise to that crampy feeling. Breast tenderness is very common in pregnancy, especially in the first trimester, and sometimes they are unusually sensitive to touch, as I mentioned, in the first trimester, and but the sensitivity of the breast is more throughout pregnancy, and some women feel so hypersensitive to it that they might want to have, they would prefer the breasts not to be touched at all during the entire phase of pregnancy. The partner should know which touch is comfortable to the woman and which touch is not comfortable, which one is welcome and which one is not welcome. So gradually, as time goes on, the partner during this phase of pregnancy should understand which touch is comfortable or welcome and which one is not. If the woman is not enjoying the act, the couple can indulge in other forms of non-penetrative intimacy, like hugging, kissing, and the other, oral forms, or self-stimulation. So the non-penetrative forms can also be tried. The couple has to experiment and make adjustments and find out which suits them the most. The woman may feel too tired, moody, or nauseated to make have physical intimacy, especially in the first trimester, and she may sometimes feel overwhelmed by physical and emotional changes. Libido can return after the morning sickness and fatigue have eased up. That is after the first trimester. And so, as I mentioned, usually in the second trimester, things usually improve in most of the women. Desire can, however, wane in the third trimester, as I've mentioned, particularly in the last month, because of, the growing belly, and, the woman is now anxious because the childbirth will actually take place very soon. So because of all of these factors, the last month can be very difficult for her as far as this aspect is concerned. She may feel too big or exhausted to, engage in this kind of activity. She may feel self-conscious about her body. She might be preoccupied with the approach of labor and birth, as I've already mentioned. So some studies have found reduction of orgasm, and clitoral sensation may reduce also during pregnancy. As I mentioned, enhanced blood flow can work different ways in different people. Some people can have increased sensitivity, some can have, it might feel a little painful, so might not like it, but by and large the clitoral sensation sometimes goes down in during this phase. Non-coital behavior is preferred by many women, as I already mentioned. The other non-penetrative forms might be more welcome. But a woman, obviously, this is a very vulnerable phase of her life. She's going through a very important phase, and she's unsure of whether all will be well and all. So she needs that, comfort. So that some kind of physical intimacy, though it might be non-penetrative, that is very, very welcome to most of the women, and that is what her partner has to understand. According to the Master and Johnson's sexual behavior of pregnant women, it usually remains unchanged or decreased during the first trimester, improve function in the second, and again decrease during the third, which I already mentioned. But according to Bancroft, the sexual problems are linked to emotional and marital satisfaction and may not be related to trimesters. The couple should keep the lines of communication open and support each other to the best of their abilities. Now, as far as whether the baby will be harmed, that is the major concern in many couples, and sometimes the partner is too scared that if I engage in physical intimacy, then probably if something goes wrong, I will be considered the villain by the family, and sometimes the woman herself is scared. So this is a very, very important factor that we have to talk about. So we have to explain and reassure them that the baby does not usually get hurt by penetrative physical intimacy. The thick mucus plug guards against infections and also physical trauma, guards against physical trauma as well. The amniotic fluid is a big cushion, and also the strong muscles of the musculature of the uterus, they also protect the baby. With the orgasm, the baby may move around a little more, as I mentioned, because of there are contractions as well, and that is also because of the tachycardia that takes place as a result of the orgasm. When should now the important thing is that we keep saying that it is safe, it is safe, it is safe, but when should we ask them to be on guard? So in cases of high risk pregnancy where there is PIH, diabetes, severe anemia, multiple pregnancies, obviously undiagnosed bleeding, or even if it's diagnosed, obviously placenta previa, we will definitely ask them to abstain, totally abstain. Then there is painful situation, premature contractions. In case of PROM, low-lying placenta, I've already mentioned, previous bad obstetric history, recurrent miscarriages, RPL, cervical incompetence that we already know of, and the partner having herpes or other STIs. So now the question is it normal if there is no physical intimacy during pregnancy, specifically the penetrative intimacy? So it can be normal. In many people, it can be normal because the pregnancy hormones can reduce the libido. But if one feels positive about the pregnancy and the associated changes, one can feel more attraction towards the sexual activities. If the woman is unhappy or feels insecure or has relationship problems, then it can have a negative effect. What is normal? As I keep on repeating, that it can be normal in one person, it might be different in another woman, and in the same woman it can vary in different phases of pregnancy, or in the same woman it can vary from one pregnancy to another. In the first pregnancy she might have had no desire whatsoever. In the second pregnancy it might be different. So it can vary, and not only from one person to another, but also in the same person during different pregnancies. So the partner's behavior, the man can feel as attracted as usual during the first and the second trimesters. And it has been found, studies have shown that usually he feels less interested in the third trimester because of several causes. First of all, the woman's belly is too large. Secondly, they are looking forward to childbirth and are a little anxious of whether any kind of physical, penetrative intimacy can give rise to problems or can induce preterm labor or those kind of things. So they are a little anxious. And that is why usually in the third trimester, the interest might actually go down. So the various reasons why, they are concerned. Fear that the physical or penetrative intimacy can hurt the baby, worries about the wife and the unborn baby's health, apprehension about the burden of parenthood, self-consciousness about making love in the presence of the unborn child. Doctors should discuss the fears and concerns with the partner and reassure and advise him accordingly. Is oral sex safe during pregnancy? This is a very important issue that I want to touch upon. Generally, oral intimacy is fine. It won't harm the baby, but one should avoid blowing away into the vagina, because there is a theoretical possibility of air embolism, and not only theoretical. In world literature there have been cases. There are a handful, maybe more than a dozen cases of actually happened, where the case fatality rate was very high. So this can be fatal, as I have mentioned. If it is safer to stick to kissing and licking the local area rather than blowing air inside. So that is one thing that we should warn when the patient is open with us and asking us questions. This is one thing that we have to tell them, that this is something that should be avoided. So now the various positions that are safe. As the pregnancy progresses, as the belly increases in size, missionary position becomes very uncomfortable, and that is why it should not be, practiced. Woman on top gives more satisfaction and can cause less harm and less discomfort to the woman. Lying sideways is a very comfortable position. With woman coming to the edge of the bed with the partner either standing or kneeling is also a very comfortable way. So the missionary position is one that gradually, as the pregnancy progresses, might be difficult. Doggy position is also preferred by many people, and sitting on the partner's lap and facing each other, that is also another way where many couples find it very comfortable. With a little experimenting, each couple should work towards finding techniques that are suitable for them. Communication and openness are the keys to maintaining or improving sexual satisfaction during pregnancy. So various dysfunctions during pregnancy, they happen in other situations, as we have been discussing at length in the previous panel discussion, but more so in pregnancy. So there can be reduced libido, as I've already explained, anorgasmia, dyspareunia, all of this mostly because of anxiety, fear happens. And second, the male dysfunction secondary to the female dysfunction. Therefore, there will be reduction in desire. There can be PE and also erectile dysfunction. All of these can happen secondarily because the woman is not interested. She is scared. She does not want to, engage in these. That is why secondary, this can also happen to the male. So coming to the factor of preterm labor, the risk of preterm labor differs amongst pregnant women depending on the presence or absence of specific risk factors. These include previous preterm labor, multiple gestation, and cervical incompetence. Theoretical mechanisms of induction of labor by sexual activity is there. Nipple and genital stimulation may induce oxytocin release from the posterior pituitary, causing uterine contractions. Prostaglandins released from the mechanical stimulation of the cervix may cause cervical ripening. Prostaglandins in semen may cause cervical ripening. We've already discussed this. Now, the vaginal infections and prematurity. When we are talking about this, the study group found that women who had frequent intercourse and were colonized with trichomonas, mycoplasma, or bacterial vaginosis, BV, were at increased risk of preterm delivery. This is something we all know. Over the years, we've been studying this and hearing this at every conference. Now, frequent intercourse in women without such colonization was not associated with preterm delivery. Only when there is colonization with these and there is frequent penetrative intimacy, then the possibility of preterm birth goes higher. But without the colonization of these kind of bacteria, the fact that only physical intimacy is causing this is actually not true. So women at low risk, like Mills and co-workers, found more than 10,000 singleton low-risk pregnancies and found no increase in the frequency of preterm labor in women who abstained from sex compared with those that actually had it. So there was hardly any statistical difference between those who abstained and those who did not. So by and large, the preterm labor is not associated with physical intimacy. Women at increased risk. There is limited evidence to guide recommendations on sexual activity in women who are at increased risk of preterm labor because of a history of preterm labor, multiple gestation, or cervical incompetence. Yet these are the women who are usually advised to abstain, as I mentioned, because if we don't know what to say, it is better to say that yes, you abstain, because in that ways we feel that we are safer. Later on, we don't get blamed. So coming to fetal distress, several studies have researched potentially negative effects of maternal sexuality on the well-being of the newborn infant. Although coital frequency during pregnancy has been associated with fetal distress and perinatal deaths, these studies suffer from either being very small samples or incomplete control for confounders. So the study's sample size was not big enough for us to come to any conclusion. So larger and more representative investigations have observed no overall association between sexual activity and either fetal distress or perinatal mortality. So there is not that much of a correlation between these negative fetal effects, and hence whatever studies are there cannot give us any concrete evidence, and hence there is actually no relation between any negative effect on the baby as far as sexual activity is concerned. Vaginal bleeding. Many women will experience some kind of vaginal bleeding or spotting after coitus, especially during the first trimester of pregnancy, and will continue to have a successful pregnancy. Medical attention is warranted only when the bleeding or spotting continues for several days or is like the amount is more and associated with pain, cramps and all, then they should, with only a slight amount of spotting, they need not fear anything. Only when it is persistent or it is the amount is significant, then they should report to us, and then we will investigate and find out whether something is the matter. PID. A common misconception is that pregnancy is protective against STIs and pelvic PID. This is not only false, but may also contribute to a delay in treatment with substantial maternal and fetal consequences. Theoretically, pregnant women should be at decreased risk for developing PID because of natural barriers to ascending infection created by the mucus plug and the obliteration of the uterine cavity by fusion of the decidua capsularis and parietalis by the 12th week of gestation. However, the upper genital tract is still at risk for ascending infection. A large chart review showed that pelvic PID and pregnancy can coexist and should be on the differential diagnosis for pregnant patients presenting with abdominal pain. So whenever there is pain, we should rule out PID. Venous air embolism, I won't talk about this anymore. I've already explained in detail. So in literature, there are 22 instances of such venous air embolism associated with blowing in air, and 19 of these 22 occurred during pregnancy or puerperium, and 18 women also succumbed. So this is something that we have to discourage. For venous air embolism to happen, there should be two things: direct communication between the source of air and the vasculature, and a pressure gradient favoring the passage of the air into the circulation. So during pregnancy and the puerperium, there's direct communication from the vagina to the distended uteroplacental vasculature, and air can be forced into the cervical canal by oral insufflation or by the piston-like effect of the organ. Air introduced into the venous circulation and pulmonary vasculature can result in serious morbidity in addition to cardiopulmonary arrest, as we all know. Although this entity is rare, pregnant patients should be advised to avoid this kind of intimacy. Penovaginal sex, especially in the rear entry position where the level of the uterus is above the level of the heart, may also increase the risk of embolism. So the doggy position or the rear entry, this is something that they should be warned about, that this kind of a mishap can occur. So now resumption of coital activity postpartum has many complicating factors: tiredness, lack of sleep, stress, and commonly reported in the postpartum period. Traditional postponement of penetrative physical intimacy for 6 weeks after delivery was based on fear of introducing infection through the open cervix and fear of harming the vaginal and perineal sutures. This standard did not, however, consider individual variability of interest and physical comfort and the actual experience of the patient. Sexual activity may generally be resumed when the entire system heals, like the vagina, cervix, uterus have healed, and there is cessation of the lochia. So the uterus healing we know by the lochia, then the local episiotomy wound, if there is any cervical tear, that gradually heals after the woman feels comfortable, then she can engage. So in the first 6 to 8 weeks postpartum and during breastfeeding, the sexual arousability of the mothers is physiologically reduced. Walls of the vagina are thinner and the orgasm is less intense. So there can be a lull in the actual desire or, wanting to proceed with the act. High levels of prolactin in lactating women suppress ovarian estrogen production with consequent changes in the vaginal. This is a very important point, that it changes the vaginal lubrication, reduces the lubrication, and also causes the atrophy of the vaginal epithelium. And that is why it can be painful also. There can be less lubrication, so it can be painful. And because of the atrophy, there can be disturbances. So the woman need not be disturbed as far as this issue is concerned unless and until she feels comfortable. So after around 3 months postpartum or after breastfeeding has ceased, the changes gradually regress and some women then experience orgasm or increase in the desire. So FSIAD, if any, that will also change, and she will feel as comfortable as she was pre-pregnancy, in the pre-pregnancy period. So the sexual function can be influenced by a woman's ability to adjust to motherhood. Often this transition period can be accompanied by concerns of confinement or lack of personal freedom. The birth of a child unalterably changes a couple's relationship. Many mothers and fathers are afraid of resumption of intercourse, and because in many houses, in the first 1 or 2 years of life of the newborn, it is normal for the child to be with the parents, and so there can be, they can feel uncomfortable with another person, however small the child might be, not understanding anything, but sometimes the couple feels very uncomfortable with someone else being with you. So we all know about the entity called postpartum depression, and this can adversely affect a woman's sexuality and desire for intercourse. Couples should allow adequate time for both the partners to adjust to the physical and psychological changes associated with pregnancy and subsequently parenthood before resuming sexual intercourse. When is it safe to have sex? After the birth of the child. As I mentioned, wait until the bleeding stops, the wounds are healed, even after a C-section, when the woman feels comfortable. And usually we should at least ask them to wait for around 4 to 6 weeks for everything to heal. So the normal involution of the genital tract has occurred. Usually that happens by 6 weeks. One is physically and emotionally ready for accepting it once again properly. And we should talk to them also about contraceptives. That is, if they when they resume, then if she is lactating, what to use, what if she is not lactating, what she can use. So these things also we should talk to them about. Small number of couples resume physical intimacy within the first month after delivery. Many wait till 6 weeks, and most couples wait till around 3 months. But most studies advise to resume the activity 6 to 8 weeks after delivery for proper healing. If one is not yet ready to have to begin this activity once again, the other has to continue with other forms of non-penetrative intimacy.
Sorry to interrupt you, madam, but time is up.
Yeah. So lack of the desire after delivery, we all understand the reasons. I'm just... So the other forms of intimacy should be thought of. This study also showed that the results obtained in this study showed that effectiveness of sexual health education packages in terms of improvement in the dimensions of sexual health. In order to maintain and promote sexual health of pregnant women, healthcare providers are recommended to offer sexual health training, as Dr. Neeraj Yadav has done with us all. He has trained us. And so all of us now are more or less conversant with how to deal with these issues. And the studies are also showing that when the healthcare provider knows how to tackle the issue, then our population, our women and the couples are treated much better when we are conversant with the issues. So as in our role as providers of health education and preventive care, physicians have many opportunities during prenatal care to give accurate information and dispel myths. Many patients may be reticent but would welcome these kind of decisions. So whenever there is a query, it is better that the patient asks the doctor. Better so, now that we are all trained by Dr. Neeraj Jadhav during his tenure as chairperson of the sexual medicine committee, it is better that we ourselves bring up the topic. We'll have to do it very subtly, very gently, but we have to raise the topic and we have to tell them that yes, unless these are the issues, you have these complications or you have these contraindications, previous bad obstetric history, unless these are the issues, you can go ahead. We have to tell them that yes, there can be some problems in the first and the last trimester, but second trimester probably you will not have too much of a problem. Even if the penetrative intimacy is difficult, you can try other ways out, but there is no reason for you to totally abstain. And the fact that many the seniors in the family, especially the elderly woman, they tell them that it is better to abstain. It is our job, our responsibility to tell our patients, to reassure them that by and large, physical intimacy during pregnancy is absolutely safe unless there are complications or contraindications. And it is us, we, the healthcare provider, who has to, bring up the topic and reassure our patients. So thank you so much for your patient listening. Thank you. I'm through. So I'll stop sharing.
Thank you, Dr. Queenie. That was such an amazing session. Sorry, my phone had the battery was low, so I could miss a little bit,
no
5 minutes of your talk. But it was a beautiful, elaborate one. And thank you, Dr. Neeraj Jadhav, for having all the experts and including us as well. And thank you so much.
Yeah, thank you. And all the matter was taught to us by Dr. Neeraj only. So
that's wonderful.
Yeah, exactly. None of us had any idea on any of these topics until and unless he included us in his committee and taught us and gave us the opportunity to speak at various fora. And then now we are confidently speaking about these issues. So once again, thank you so much, Neeraj sir, and all the best to you for the upcoming elections. I forgot to mention this at the beginning. We all, stand by you because you deserve to become the vice president, and we really, really hope that things go great, and best of luck. And thank you so much, sir, for joining. Nice seeing you here.
Thank you so much.
And thanks, Ankesh, for being there.
Thank you.
Thank you, chairpersons and madam, for this talk. We quickly move. We have running really late and short of time. Yeah, we move on to our next talk. I would like to welcome our chairpersons, Dr. Namrita Sheregar. Namrita is a member of the managing committee of AFG, has been a lecturer at Cooper Hospital, and is a consultant OBGYN at Andheri. Welcome, Namrita.
Thank
Our
you.
next chairperson is Dr. Ashlesha Sankhe. Can we have Dr. Ashlesha's CV?
You are muted.
Yeah. Dhaval, you're on mute.
Yeah, sorry. Dr. Ashlesha Sankhe is consultant at Max and Cloud9, and she's a director of Serenity Clinic at Andheri. Welcome, madam. Could Namrita introduce the next speaker?
Yeah. So at the outset, I would like to thank AFG and Dr. Neeraj Jadhav for inviting us and for taking up this really untouched, sensitive topic. So thank you, sir. And I would like to congratulate all the speakers so far. I think we've had an amazing, session so far, and everything was like, we all have learned something. So without any further delay, I would like to welcome our next speaker, Dr. Nisargi Patel. Can we have a CV, please? I'm not able to see a CV.
That's fine, ma'am. I'll
visible.
continue.
I
I'll
will.
share my screen.
I think I've had on the phone. So yeah. Madam is a certified infertility and laparoscopic surgeon. She's also done a diploma in aesthetic and functional gynecology, and she's conducted the largest cervical screening and vaccination camp in north of Gujarat. So we welcome you, ma'am.
Thank you, ma'am. Can I share my screen, ma'am?
Yeah, yeah.
Okay. Is it visible?
No, not yet. At least I cannot. Yeah, now we can see.
Okay. Good evening, everyone, and thank you, Neeraj sir, for giving me this opportunity, and all the best for your next election. As a healthcare professional, we are often as a frontline guiding adolescents through one of the most complex transition in human development, like puberty, identity, and sexual awakening. But recent study shows like 70% of adolescents they are having questions about sexuality, but they are in few people only they are able to discuss with their friends or healthcare worker. So education is very important. Let's talk about growing up and growing aware. Body, mind, and more, understanding adolescence from curiosity to clarity. So what's adolescence? So adolescence is the typical a period of transition between the childhood adulthood with the psychological task, being the determined identity, develop power to make decision and be in control, and develop mature sexuality. How sexuality develop over the period in adolescence. So it's early adolescence in 10 to 14 years. Kids are very shy. They need privacy, masturbation, rarely into the romantic relationship and short life and shy modest. But while growing, then in middle adolescence, they focus on sexual attractiveness, frequently changing relationship, and fear, discomfort, tenderness, and passion may develop. But while in late growing age, they have a serious relationship, clear sexual identity, capacity for tender and sensual love, and abusive behavior may be present. What's difference between the sex and sexuality? So sex is physical act of intercourse, intimate expression of love, while sexuality is sum total of one's thoughts, feelings, behavior towards opposite sex, total expression of who we are as a human being. It's more than the act of sex. It includes physical, emotional, and spiritual part of our being, and it involves our personality, value, attitude, and gender, thoughts, feelings. Even sexuality is constantly evolving as we grow up and develop. Adolescent sexuality is changing as the adolescents now attain puberty earlier than before. So, components of sexuality, gender-based persons is biological and anatomical, like a male, female, intersex. Gender identity, like a girl, boy, man, female, a man, woman, transgender. Sexual orientations like heterosexual, homosexual, and bisexual. And gender presentations and expression like feminine, masculine, and androgynous. So anatomical and biological sex, it's only one component of sexuality. Organs with which you born, it's like born, boy will be with penis, testicles, girls with breast, uterus, vagina, ovary, androgynous genitalia or intersex with sex organs that are not well developed or maybe resemble with both sexes, and biological sex is determined at the time of conception. Gender identity is the psychological sense of one's gender. It may be cisgender or transgender. Gender identity and anatomical sex sometimes don't match. A male or female who feels strong identifications with the opposite sex. Person can be born as a boy but feel like a girl or vice versa. That's called transgender. Do you feel like a boy trapped inside a girl's body? Combinations of feeling. Transgender gender identity is different from sexual orientation, and transgender have same diversity of sexual orientation as a cisgender, and they have social affirmations, legal affirmations, medical and surgical affirmations. According to DSM-5 definition, gender dysphoria it's marked the inconvergence between the one's experienced expressed gender and assigned lasting at least 6 months and causing consideration distress may include a desire to primary or secondary sexual characteristics. Not all transgender or gender diverse people shall experience dysphoria. Gender identity is different from gender expression. Gender expression is the way in which one would present to the world in gender way. Maybe like the female wearing a tuxedo and it's masculine, and male wearing the dress in a feminine expressions. Diverse gender expressions like diverse gender identity are not indication for mental health. Sexual orientation is influenced by anatomical sex, gender identity, and by society. If you are sexually attracted to a person of the same sex, then it's called homosexual. Opposite, it's heterosexual, and both sex, it's bisexual. So, what asexuality? No sexual attraction to a person of either gender. Confusion about sexual orientation. Sexual identifications with homosexuality, bisexuality starts during adolescence. It's very common for young people to get confused. It significantly implications for their sexual and mental health. Now feel isolated, scared because of their orientation, and maybe they develop life affirming health behavior. Adolescents and adults should be comfortable with aspect of sexuality in that anatomical sex, sexual orientation, sex, gender identity. Sexual orientation and gender identity are not by choice, but it may be shaped by both biological and environmental influence. And maybe treatment is mainly for secondary problems like depression, anxiety, and other problems like psychosocial therapy, family, and individual therapy. Sex changes surgery conflicts within the sexuality. Its younger age of menarche, urbanization, industrialization leading to losing of family ties, erosion of traditional sex as a taboo in family. They won't discuss about sex in family or friend, and sexuality explicit material on internet, opportunity of social media and peer pressure. Gender cross culture and influence, our adolescent men are taught that being sexually active is important part of being a man, and they encourage to obtain sexual initiation without condom, and they don't know about STI, maybe regards as rite of passage for muscularity. But female adolescents receive positive reinforcement for being quiet and unaware of sex matter. The non-aggressive taught to abstain from sexual activity and get married off to older men, non-assertive and without reproductive rights. Paucity of existing sexual and reproductive health progress for adolescents. Sexual and reproductive health needs of adolescents should be treated as a basic human rights, rights to privacy, confidentiality, respect, and informed consent. Consequences of unchecked adolescent sexuality, it's end up with teenager pregnancy, unsafe abortion, STIs, cervical cancer, psychological impact, and sexual abuse, violence, and sexual crime. Adolescent sexual health is an important healthcare issue of 21st century. So we have to teach them about adolescent contraception. Teenager pregnancy, it's called when pregnancy from puberty to 19-year of age is teenager pregnancy or adolescent pregnancy. Pregnancy can happen even before menarche with the first sexual act. Pregnancy is the biggest abuse of childhood, and it's in developed country also because of early marriage and traditional gender roles. In developed country because of unplanned sexual activity. So issue is developed which is gradually gripping in India also in urban teenager as well. As a National Family Health Survey of 2015-16, 11.9% of 15 to 19-year-old girls were married before the age of 18 in India. Even the various states. Further analysis revealed that 27.3% of married teenager girls have birth to one child, while 4.2% have two or more children. That contributing factors, prevalence of the girl child marriage is found more common in rural area than the urban area. Poorer the household, higher chance of girls getting married early because of dowry demand, sexual assault, especially in the rural area, and suitability issues. Because of that, it's increasing with the age, and that contribute the lack of sex. Because of the lack of sex education, the lack of education of contraception and contraceptive use, deep-rooted patriarchy and social control, women's sexuality, rape, incest, sexual violence, commercial sex, addiction of alcohol, smoking, substance, stress, depression. Women don't have reproductive rights, find it difficult to impose protective behavior. And because of that, medical consequences of teenager pregnancy occurs very frequently in developed country because of poor antenatal care, because of higher incidence of medical complications such as anemia, hypertension, preeclampsia, PPH, endometriosis, obstructed labor, and because of that fetal distress and other things. Because of that, patient will end up with cesarean section and operative delivery, even though postpartum depressions also. And because of that, they have that child rearing and motherhood, poor parenting problems, higher incidence of abortion and especially unsafe abortion, psychological manifestations of unwanted pregnancy, anemia, malnutrition, poor bone health, and sexual transmitted disease with cervical cancer. This occur because of loss of social and personal educations. Maybe education status may be irreversible, stigmatized for unmarried girl. History of abortion before marriage can make her social outcast, forced to give a school. Pregnancy, employment, development of the girl, loss of the ability to achieve in society, and low self-esteem, plus integrational early pregnancy. These young girls are more vulnerable to higher incidence of sexual violence, higher incidence of domestic abuse, and substance abuse. And because of that, teenager pregnancy, it's very common. So for that, we have to give preconceptional counseling. We have to educate about contraception, access to abortion service, optimal antenatal care, correction of anemia, looking after nutrition needs for pregnancy and teenager, treating as a higher risk pregnancy and institutional delivery, and support that child rearing. Prevention of teenager pregnancy, delaying the marriage of the girls, as the most pregnancy in India still happen within the country. The most significant factor is delaying the age marriage is completing the education of girls and empowering them. So, unsafe abortion is the third most common cause in our country for maternal death. And nearly 6.4 million pregnancies are terminated every year in India. And as per WHO, around 7 million women are admitted to hospital every year in developing countries as a result of unsafe abortion. Every 8 minutes, woman is died because of unsafe abortion in developing country. And of this, who survive unsafe abortion, majority will suffer long-term health complications. So WHO deems unsafe abortion one of the easiest preventable cause for maternal mortality and staging public health issues. Unmarried adolescents decide to terminate their pregnancy and frequently than other group. So 1 to 4 million adolescents undergo unsafe abortion and attend consequences. So adolescents who are 15 to 19 years of age are at high risk for dying from the abortion and related to higher complications. Adolescents may not understand the science of pregnancy, may not be aware of abortion, safe abortion techniques, legality of abortions, and location of abortion causes. So we have to guide them. We have to restrict customs and law in some cultures, obsessions towards having a male child, poor ability on accessibility of the service, and 70% of Indian population live in rural setting, but safe abortion services are very rare. So they are going to over the counter and they are getting MTP kit over the counter. Legal aspect like marriage, it's less than 18 year in female and less than 20 year in male, it's illegal. So constitutional homosexual intercourse is no longer is a crime offense according to section 377 IPS, and this overruled by Supreme Court. The MTP Act abortion rules, Child Helpline 1098 and the POXO Act 2012. The law to protect child from the sexual offense. What is POXO Act? When pregnancy is less than 18-year married girl, it's called rape. Even if consensual less than 18 years is statutory rape, and married less than 15 years, if pregnant, then it's rape. In 16 to 18 years, it's rape, or according to IPC 375, it's POCSO. And Supreme Court judgment judgment is given by Supreme Court 3 years back. It's inform the police. Whatever will be there, like 18 years, less than 18 years, then we have to inform police. Even married person will come and she is pregnant, but her age is not. Then she got pregnant, and that time she is not 18. Then even though we have to inform police. So how will teach them contraception? Preventing pregnancy, adolescent is high priority. So we have to give them knowledge, and we have to explain about contraception. What is the benefit of contraception? We have to tell them. So it's highly effective. We can prevent STI, HIV, and it's independent of compliance, have no more and little health risk. Even though they are having some medical problem, that is also correctable, like bleeding irregularity, dysmenorrhea, PCO syndrome, acne. Even protection against, we have to teach them, it's protect against pregnancy and STI. And every parent should know about this emergency contraception, because adolescents parents, they can, if their kids they are sharing with their about their partner, then they have to advise them using this emergency contraception. Even we have to encourage them for long acting reversible contraception like IUCD, combined OCP, vaginal ring, transdermal patch, progesterone only pills, male condom, and emergency contraception. And we have to explain them what is the benefit. This STI is raising concern, and the problem more serious than those pregnancy with long-term consequences, like the cervical cancer. This epidemic is one of the results of sexually saturated culture, and the perpetrated by the latex contraception and vaccine can be, all behavior risk will be free. So we have to advise them contraception according to CDC guideline 2017. Young people aged 15 to 20 years develop half of all new STIs, and 1 in 4 sexually active adolescent females has a STI. 1/4 of adolescents and young adults in high-risk age group for STI don't have healthcare coverage. Only 11% of teenagers surveyed reported getting most of their information regarding STI from their parents or the other family member. Sexually transmitted disease like HIV, HPV, gonorrhea, herpes simplex virus, hepatitis B, C, syphilis, trichomonas. Causes for not seeking treatment: confidentially concerned, lack of privacy, non-availability of special center, poverty, long QS, reluctance to approach male provider, judgmental attitude to the staff, own perceptions of causes of disease, inability to understand magnitude of problems, and social stigma. Preventing STI, we have to identify high-risk groups, including the responsible behavior, contact tracing, pap smear in older age group or whoever is sexually active, promoting HPV vaccine, 2 doses in less than 15 years and 3 doses above 15 to 26 years of age. Even male, irrespective of male and female, we have to advise both them HPV vaccine. Responsive behavior like non-hurting yourself, non-hurting other person, extremism, be faithful, condom, contraception, disease alert, and consent is must from both partners. If you don't take a detailed sexual history of your partner on your date, you don't know him very well enough to have a sex. And safe sex is the sex with your faithful partner. So in few months back, 10-year-old girl with alleged with gang rape by 8 boys, and 7 of them are the underage. They are adolescents in between the 10 to 15 years of age. Sexual grooming, it's subtle, gradual, calculated, and escalating process of building with the child. Deliberate the purposeful. Abuser groom children over the week 2 years, maybe online, face-to-face, stranger or someone known, female or any age. Stage of grooming, targeting the victim to gaining the victim trust, and isolating the children. 5 sexualizing relations. 6 main control. So history taking tips for dealing with sexual issue with adolescent is very important. Always greet him or her in friendly manner. Be open and flexible and relax with them. Be honest and simple. Respect his or her point of view. Don't judgmental Don't be a judgmental. What is not normal should be expressed in soft tone. Never be disproving or but explain the risk in the scientific manner and teach them what is bad, what is proper things, and teach them contraceptions also. Sexuality education is more than the instruction of children and adolescents on the anatomy, physiology, biological sex, and reproduction. It's cover healthy sexual development, gender identity, interpersonal relationship, affection, intimacy, body image for all adolescents, including adolescents with disability, chronic health conditions, and contraceptions and STI. So common myths like sexuality in education leads to early sex depend on children of their innocence. Only parents and close relatives can educate them adolescents about sexuality. Parents object to sexuality education being the teacher in the school. Sexuality education is good for young people, for young children. Abstinence is their solution. Sexuality education should only be promote value, reduce misinformation among the youth, increase communication with parents or trust adults. Adolescents delay the debut of sexual relationship and the frequency of unprotected sexual activity and unintended pregnancy and STIs. So key message is adolescent sexuality is influenced by many factors including gender identity, sex orientation, and belief in the biological development. Though it's normal for teens to want or experience physical intimacy, but they may not be able to understand the consequences of sexual activity for themselves or their partner. Reliable information delay sexual activity. They should be understand that is desirable till one is mature enough at 21 year. And first talk the talk, then walk the walk. So mainly key message is like we have to aware our adolescent group and we have to give them as much as possible about awareness in every school and every society. That's very important. Thank you for listening.
Thank you so much, Dr. Naisargi Patel. You covered almost everything about the adolescent sexuality from postcode to teenage pregnancy to addiction, sexual transmitted diseases. But what I see nowadays in today's adolescent age group, whoever I see in my clinic, they have a bit of gender identity problem, whether it's a fashion.
I think it's peer pressure also somewhere, and there's so much of exposure on social media and all these places. I think that is why they are a little confused or rather curious.
Because of lack of education, ma'am, they are not able
Yeah.
to ask anyone and they are seeing in YouTube or social media. So that is
Yeah.
misinformation and misguidance. So because of that,
Absolutely.
more problem is suffering.
Yeah. So I think sex education is a very important aspect, which is, I think majority of the schools, they've started inculcating it in the curriculum, which is good.
Even
And
ma'am, Foxy started under sexual education sex education this committee by Neeraj Yadav sir and Apurva Datta sir, Prayas group. That will teach from 6th standard to 10th standard boys what is
Yeah.
sexual this education, puberty and everything. They started in February.
Yeah. So
That
that's,
new
I think it's a very
project is
good
there,
initiative. Yeah.
Prayas.
So, and something which we probably as parents, we should start it at home with our own kids.
Yes,
So,
ma'am.
at least we can, when there's some awareness. And it's, as you said, it's better to give them the right information rather than they getting information from somewhere outside and in a wrong manner.
Yes.
And something which I tell means, when a lot of patients come to me, I said it's okay to have sex, but with the right person at the right time. I've had patients who've come and asked me, when the young girls, 17 to 18 years, they ask me, what is the ideal age to have intercourse? Said there's no ideal age. You should have intercourse when you are comfortable with yourself and the particular person. It's just not a like, just because somebody else, she was like, everybody else around me is sexually active except for me. I said, it's okay, it's completely fine. So that I think we have to make them aware of that. It's okay to, just accept the way things are. And once you are comfortable, your partner is comfortable, then you go ahead with something like this.
And ma'am, actually nowadays in educated people, we are seeing so many STDs cases
Absolutely.
nowadays. That
Actually,
is
they
one
are
of
aware of
the
STDs, surprisingly, because thanks to Google and YouTube, they are aware of STDs, and most of the time they come to us because they have heard of STDs. not because of anything else, And they're like, I just had intercourse, and do you think I could have developed an STD? So that is again, then, we have to explain to them, you cannot just randomly develop any STD just like that. You have to, contraception, condoms, and that's where, everything, if you have multiple partners. So I think so it all boils down to you have to educate them.
Okay,
Thank
Can
you.
I add one point, doctor?
That's
Can
for
I add one
teenagers.
point? Yeah. Yeah, Dr. Naisargi, what do you think? What should be the ideal age for the adolescent to have the sexual intercourse?
Ma'am, I
What is
think
your view?
after they
Very
should
subjective.
have a detailed knowledge, ma'am, and after 18 is the age, ma'am, not before 18. And that was also they should have proper contraceptive knowledge.
Do you think the cervical epithelium and the reproductive tract is quite mature to expose for the sexual activity at that age? Because I am little bit not so sure about.
No, no, ma'am, it's not there, but it will tell them also. Nowadays, people are so like they know have more knowledge because of social media, and they won't agree with our like what we'll tell. Like after 21-year age, you because this anatomically it won't develop, physiologically it won't. They want so better. We'll protect them by HPV vaccine. We give them proper contraceptive knowledge, and we can tell ideal age is after 18 because they won't listen us. Otherwise, they
Actually, they
won't
won't
come
listen
and
to
get.
you.
We tell
They'll go
them
to
like,
another gynac, Ashlisha madam. They'll go to
Yeah,
probably another doctor who will, listen, who will agree with what they say.
Okay,
no, ma'am,
thank
we
you,
just
Dr.
At
Naisargi.
one point we are
To
saying that the
wind up.
cervical cancer incidence is high, and at one point they are all into this smoking, early sexual activity without protection, STI, everything.
so,
It's a
ma'am, what
contrast.
I'm doing here, ma'am, like I'm attached with Rotary Club. So every week I'm giving education about sexual education and cervical cancer awareness. And I tell them like before getting to sexual act, you have to be protect with HPV vaccine. So almost in our district, we have given vaccination to almost 7 to 8,000 girls.
Wow, that's really amazing.
But
That's nice.
everything donated by people, ma'am.
The
Nothing.
Supreme
I think
Court has
cost is a
also.
major factor because of the cervical cancer vaccine cost plays a major role.
And we
Yeah,
are giving pamphlet also, so they can go and they can give to their parents also, like what is the problem, what is cervical cancer, why STDs occur. So they can be literate by like that. In local language, we are giving.
I think it's time to
Dr.
move on to
Aslisha is
our
correct.
next talk.
Thank you
We are
so much.
really
Thank
running
you,
short of
SG,
time.
for
Thank you,
giving
Dr.
this.
Naisargi. Thank you, Namrata.
Thank you,
Thank you,
sir.
Dr.
Thank you.
Ashlesha, for this session.
Thank you.
We
Yeah.
Excellent conduction, Dhruv. You've conducted it so well, Dhruv, and it got
Dhaval.
overshot, but we have
Dhaval.
done so much this thing discussion over here. People have actually spoken from their heart, I felt, from
Yeah,
their
they have.
practical knowledge.
I know.
Excellent program to Nitin Shah sir and you, very well conducted. Excellent work.
Thank you, Ankesh. Thank you.
God
We'll
bless.
quickly move on to our last session for the day. I would like to welcome our chairperson for this session. Our chairperson is Dr. Gautam Sonavne. Gautam is a senior consultant gynecologist and endoscopic surgeon at multiple hospitals in Bombay. His primary area of practice is Andheri. He's a managing committee member of MOGS, AMC, and a youth council member of the AFG. Welcome, Gautam. Could you please introduce the speaker?
Thank you, Dhaval. It was a wonderful session. Now we'll move on to next session.
I think network issue Gautam is having.
Gautam, I think you are in a poor network, Gautam. Could you?
She is the South Zone coordinator for Sexual Health Committee and STI Committee.
Okay, Shama madam, over to you.
Yeah, thank you, sir. So I'll share my screen without any delay. Uh, Is it visible?
Make it full screen. Still, it is not in full screen. No problem.
So our topic today here is sexual history taking. Many of the points were covered in the panel discussion and also the talks, which are wonderfully taken. So this is essential for actually this is a process where we gather some information about the patient's sexual practices and behaviors and also experiences. And it is a crucial part of the healthcare where there is a gynecology and obstetrics is required, and also sexual health concerns is required, and also various reproductive medicine concerns are required. So when a woman is going for some concerns like problems in sexual dysfunctions and relationship issues, psychological factor issues, where there is a shy or shame for related to sex concerns, and poor body image, if she is fat or if she is not looking good in during the menopausal stage, she will feel so in such circumstances, and infertility issues, postpartum issues, and menopausal times, infertility treatments, and when coping up with the STIs, women seek for sexual health issues to specialized healthcare providers like obstetricians and gynecologists and sexual health specialists and infectious disease specialists and mental health specialists. So they will take the sexual history where the routine health as a routine healthcare checkup. Also, they can take the sexual history, and also when there is a physical examination and about STIs, they have come to know after the examination, they can take the sexual history. And the adequate sexual history should be tailored to each person based on their preferences and the clinical situation. And the providers may need to modify questions to accommodate a person's gender identity and also race, ethnicity, culture, or other important considerations. So many doctors nowadays, what they feel in first go is about the ability to take appropriate history in case of sexual problem, and patient and doctor are embarrassed and uncomfortable as they don't want to share their personal issues in one go, and patient may feel ashamed or even humiliated to ask for help with a sexual problem. Some hospitals may give pre-consultation questionnaire sometimes when they are sitting in the OPD, but filling that also they will feel that they will come to know about these all, and they will be embarrassed, they will be encountered some problems in the family or with the spouse, they will be very much encountering few issues, but it may be becoming an embracing situation later. So this sexual history taking should be understandable, like it will be a confidential one. This is especially important when taking a sexual health history to build up trust with the patient, that when they speak about their sexual health concerns, it will not be speaked out to any other person without their knowledge. So safeguarding their issues, concerns, like if they have any suicidal tendencies about it or any sexual violence have taken place, we have to safeguard those all instances. And risk taking behaviors, like we need to tell them that if there is any chance of means contaminating with HIV or recreational drug use is there, we need to make them understand that the real things. And prevention of onward transmission, like if they are exposed to some HIV person or any partner who they are having means a sign of thinking they may be transmitted with HIV also, we need to make them understand. So, opening the consultation, you need to first introduce yourself coolly, calmly, sitting in your PD or any other consultation place. You have to be very coolly, calmly sit and make yourself, introduce yourself, and your body posture should not tell them like you will just judge them or see through them like a bad or something. Patient details you need to ask, like name, address, where you have lived or what you have done till now, like that few questions to make them very close to you, and like that some rapport should be made first. Then closing consultation should be summarizing the whole history before them, and make them understand if they want to ask any other questions or reaffirm confidentiality, this we will not going to tell anybody. And lastly, don't forget to thank the patient to trust you. And then when you are initializing the conversation, you need to be very clear that shall I ask you a few questions about your sexual health and sexual practices you do. And if it is very personal, about it is very personal, I understand, but it is very important to your overall health. You need to make them understand very clear. And and this point of time, generally we ask patients and regarding about sexual life, if concerns are like this bulky, you need to make them understand. And regardless of age, gender, marital status, we generally use these questions to solve your problem. So we are going to ask such questions. So areas of any physical or mental health, we usually ask these questions bulky. You need to make them very cool and confident about you. So someone else being hurt or in danger, they should not feel like that. And do you have any questions bulky, we need to ask before we get to start, because it makes somewhat easy if they come upon directly sometimes. So do you have any questions, concerns about sexual health? You can ask directly or slowly you can go into it. So key points we need to see before we go into the matter. So we need to have some knowledge about, we need should not means we have to avoid moral or religious judgment of the patient's behavior, and avoid terms to make assumptions about sexual behavior or orientation. We should not assume on the go. They have to come upon, like we should not ask how with how many people you have had sex. They just, we need to ask them, are you monogamous, are you with a single person? Then they will come out. If they trust you at that moment of time, they will come out, no, it is not my first encounter, or it is not the only encounter, I had many encounters before. Means just a one night stand, or nowadays it is logically given some sentences like nano or micro relationships, like that. They will come to you, and they will come up to you, means they will tell you all the secrets slowly, but you should not assume things. So ensure shared understanding around terminology and pronunciation. For we have to know, the one who is taking the history have to know the terminology of each and every thing, because anatomy or the word you are using, you have to have the knowledge about it. Because if we say one word, they will again go to home and just they will google it, or just they will see it. So we should not confuse them with the other terminologies. We have to use the correct terminologies about the anything. Or if they are not using the perfect slang, if they are using some other thing for genitalia, for if they are using some word like for vagina, for some other slang, then you have to tell them the correct one. This is anatomically in normally it is called this thing bolke. You have to clearly explain them, because it may be other place they are talking about and you are misunderstanding. So you need to make them understand this thing is this. You can use some use artifact, or means you can use some means stuff, means any paper or any photo you have, you can explain on the paper that this, or you talking about this means area. So establish rapport and consent before addressing sensitive topics. You have to take a proper consent. Can I ask you about this, about your life bolke, you ask them. If they say okay, then go ahead. So respect the patient's right to decline answering. If they are saying no, I don't want to answer, just be clear, okay, later on you continue with your talk, and then afterwards just be clear that they, if they are trusting you much more, then again come to that question which you want to get the answer. So then use a sensitive tone. Don't be like, oh, you that bolke, don't make them embarrassed, or don't be judgmental. So use neutral and inclusive terms that avoid assumptions about orientation, their partner or themselves. Then logically we need to be asking at least annually about have you been sexually active in the last year. If they say yes, then we need to go for types of sex, or oral or vaginal or anal, or with men, women, or both, or how many sexual partners you have. After getting into one of the conversations, we can ask. But if they are a little more older adults, we can say how the sexual activity have changed from before to now, we can say. So it will be making us easy to presume their concerns. And if they say no, then again we need to consider the medical history. because they will be coming to you with the concerns. So at least once in a year, at least once an update as needed it is. Gender identity and sexual orientation can be fluid, because in 3 questions you can understand their orientation. You have to ask, what do you consider yourself to be? Just are you a lesbian or bisexual or another, or straight, heterosexual? Just a single question. And then what current gender identity at the time you are taking history, what the current gender identity they are thinking about themselves, and what sex were you assigned at birth. So these all things will make you understand at what sexual orientation means. If any person, I have encountered one person who have went to Mumbai without telling the in the home for a gender changing operation. So he was literally having feelings for other man. The boy who is 16 years, he was having feelings for other man. And after 2 years, he returned home. Surgery was not done because he has not having money. Again, he was encountering the same thing. He has returned to the home because of the parents' will, as they were searching him for so long. But he literally told us that he is interested in men. He is having feelings for men. So in that situation, you can just encounter that how is the sexual orientation. So getting into the normal past history and personal history. Past history, you can ask for any congenital malformation, diabetes, hypertension, as previously many people have discussed, any marriage or divorce due to some situations. After marriage, many people expectations are not satisfied. So that many of the times it will lead to divorce. Many of the times when we go into the history, what are the mentally stable or unstable partner is doing. One person was just naked and naked at home, and he was peeping out of the window. So encountering that, any woman can give divorce to a man who is doing such things and he's not interested in that woman. So in such conditions, in past history, if we encounter there is a divorce, so we need to know the past history and psychiatric history in any anxiety, headache, palpitation, anger, insomnia, and also like personality disorders, paranoid behavior is there, thought disorders are there, we need to understand. And then family history, in many of the times we see that parental dominance have made them so this much that they don't there will be many unconsummated marriages. Even after marriage, they will be not be understanding each other due to parental dominance, that after the marriage also he will be under the means pressure of mother-in-law, that women will not be able to have sync with the husband that much. So it will be a chance to have that unconsummation. And attitude towards the religion, strict or open, and sex games in childhood. Many of the in I have encountered in the girls school, they will be doing a games of homosexuality, that thinking that the girl is a boy. So in that time when they are encountered and they are before the teachers or some, they will be punished. So that encounters may some more will be pressurize them to have a much more sexuality or much more. When other sexual encounter is there, they will be very much hesitating. So that behaviors we have to know. So personal history, their diet, exercise, sleep, stress, work, and these all are very important, because as we have seen, as we have learned in previous speakers, that stress, work, the person who is going in the morning, coming in the evening, and this person is going, other spouse is going in the evening. So in such cases, there will be a consummation, and also a sexual problems can be rising mentally and physically. So medical history also, psychiatric illnesses, hormonal imbalances like thyroid, prolactinoma, as we have seen in prolactinoma cases also, there will be a loss of libido and all. So surgical histories in this also, in surgeries on vulva and vagina, there could be a loss of means vigority in the vagina, means it may be loose, or sometimes it may go for vaginismus, which may lead to some type of sexual concerns. We need to ask those. And obstetric history, pregnancies or abortions. And bad obstetric history also, many of the times they will be very much disturbed. In infertility also, they will be under the pressure. When we ask them to meet, they will be thinking it is a some sort of exam they are writing. So they will be thinking there will be no mindfulness when they are in the room. They will be thinking all about these means medication, these counselings, these all. So and what our relatives are expecting from them, all these things are will be in the mind of them. So mindfulness they have to practice. So we need to ask those. So sexual history, so number of years of marriage, consummation or unconsummation. We need to ask about the series. So what happened in the first night or intercourse. Frequency means what they do in the term courses, means they switch on the lights or off the clothes, or little bit of inside the talk we need to understand. Desire is there with the partner or no desire is there, they are happily satisfied or not. If there is a female sexual dysfunction like orgasmic dysfunction or vaginismus, they are encountering anything, little bit of data we need to collect. And male dysfunction, sexual dysfunction like erectile dysfunction or premature ejaculation. Most of the women tell us about the premature ejaculation, but they expect more. But the thing is, it is ended up in faster. So those could be the issues. So fatigue, fear, guilt, and the pressure of performance. Like husband, when he is asking for more times, they will think that he is only using them for sexual gratification and he is not loving them. They will be thinking of that and they will be reluctant. I don't know. Many of the times, many women come that their husband is not at all interested. Sometimes this and sometimes that situations come to us. And sometimes fear of failure, that they, due to some pain or vaginismus, she's not able to go for it, and that may be leading again to further sexual desire, less sexual desire. So again we need to much more sympathize on sexual orientation, where many of the boys who are gays, they are married to a woman due to family pressure, and many of the times they don't do justification to this women who is married to him. So in those cases the woman life is really shattered, and really sexual orientation really matters there. So history taking specifically to female sexual dysfunction, did she initiate the sexual activities for, or her partner is initiating? It is very much means important, because if she is initiating and she's not getting that sort of equal importance, that there is a problem. If she is not initiating even after her husband is upon her, then here is the problem of means she's not getting libido. So that's all we need to understand. She is losing the interest, we need to understand. And her response to partner's sexual advances we need to know. So usually refuse, if she is usually refusing, we need to understand, or she's reluctant, or she's not getting pleasure, or like that we need to understand. So history taking important factors could be we, as many panelists have told this, that both partners should be at the history taking. That is most important thing, and the relationship to be treated and not the individual we are treating. It's the relationship we need to treat to means end the sexual consequences. So biological and psychological information forms a complete history. So here we see the history of female sexual dysfunction. Many of the indirect symptoms like backache she may have, and pain in lower abdomen she may have. She may have vaginal discharges, dyspareunia she can have, anorexia or excessive weight gain she can have. These are the indirect symptoms she can have, and which she tells along with the female sexual dysfunction. And we need to ask them like exacerbating factor or any relieving factors are there with such symptoms, and any problems, these problems or situation or globally or day long they are having, or week long they are having, or severity is mild or moderate or severe, we need to understand. If they are primary or directly they are coming, or due to some consequences they are getting such means female dysfunction, we need to know. So in the marital history, premarital sexual experiences we need to ask, and first marital sexual experience, his or her reaction on it, and contraception if used, how it was used, and how many times or usually it is used, we need to ask. And self image is very important, how they feel about their body and their partner's body, we need to ask. And is there any change in sexual behavior and mutual relationship, if before they were okay and now they are not okay, or if before it was not, it was okay, but now it is severely means offensively coming upon, and she's have lost some desire, we need to know what do you means like the best about him or her, we can ask about. And confidentiality is really the information is really kept closed. So causation of a problem can be a single or multiple, like communication problem with the partner can could be the chance, and the social taboo, traumatic sexual experiences, like we have seen most of the abuses which are encountered in the past may now be the experience, and traumatically it may cause her inhibition for towards the sex, and homosexual orientation may cause it a problem, and anxiety, guilt, depression, and also mania, and pressure to perform, low self-esteem, dislike for partner is the most of the time dislike of the partner, and but they like the other person who is with them, attract or infatuation will be there, it may be one of the cause for the disinterest, and sexually unresponsive partner, and it may lead to many of the time infidelity where they go for the outside partners. And alcohol and drug abuse is the most of the time it will affect chemically and also physically. And this is the one of the screener, decreased sexual desire screener, where 5 questions are there, where the 5 questions will help us to have the screening of the hypoactive sexual desire disorder. So this is female sexual function index. In this 19 questions will be there. Depending on that, desire, arousal, lubrication, orgasm, satisfaction, and pain will be known by that questions. And the score on the score 2 to 36 will be the maximum score. On the score basis, we can understand the level of problem of the sexual function. So quickly, I want to say that 5 P's are there: partners, practices, protection from STIs, past history of STIs, and pregnancy intention. In the partner who is intending, they are going to have any type of sex. We need to know in certain months how they have gone for a partner or partners. We need to know. So practices, as we have seen, due to these practices we can come to know the part they are telling, the pain or something, or the type of activity or practice they are doing, we can know the part of the problem or STIs they can fall under. Then protection from STIs we can consider, and the dialogues we need to tell them as, do you know, do you and your partner discuss about STI preventions, and they, if they have HPV or hepatitis A or hepatitis B shots or not, we need or HPV, HIV, are they know about it, both partners discuss and make certain chances that they take prevention, condoms, use condoms or not, we need to understand. And past history, as I told you, any tested STIs and HIVs are encountered or not, we need to see. And pregnancy intention, if they want pregnancies, how they have to go further and how they need to be asked questions, we need to know. And as they were discussing all the panelists and about this licit model, permission, limited information, specific suggestions, and intensive therapy, these all we actually sometimes knowing, without knowing, we do this at our OPD. So this model is important. And sexual history proforma, I will share this proforma in the group as well. By this we just see that how they are coming up to the arouse means sexual history. So finishing the session, you need to tell by the end of the interview session, the patient may have come up with the information or questions that they were not ready to discuss earlier. Actually, then what other things about your sexual health and sexual practices should we discuss to help ensure your good health? We need to ask them further. And if other concerns or questions are there, they can discuss and ask the patient about the history or trauma or sexual abuse. After these all, you may have rapport with the patient, so they can come easily for you, so they can, you can easily ask such questions in the last also. Then don't forget to say thanks at the at this point, that thanks is the thing which make them understand that you have understood that they have trusted you honestly. So on conclusion, I want to say that sexual history is not an innate skill. Training is the area needs improvement. Basic principles should be followed, and practice and comfort development are essential. Appropriately taken history can impact on the patient diagnosis, patient decision making, and patient satisfaction. So thank you for patience listening. Thank you.
Thank you, Dr. Sharma. Gautam, are you there?
Thank you, Dr. Sharma. It was very crisp and detailed presentation on sexual history taking. Actually, I'm traveling, so that's why I could not introduce you properly. So it was thorough justice to your talk. Thank you, Dr. Neeraj Jadhav, sir, and Dr. Nitin Shah, inviting me as a chairperson. Thank you, Dr. Dhawal. Over to you.
Thank you, Gautam.
Entire webinar was really a fantastic eye-opener and a lot of take-home message by all the stalwarts in the field. So I congratulate everyone for delivering their best. Thank you, Dr. Neeraj Jadhav, for accepting this invitation. And thanks for getting your expert team on the panel and for this talk. Thank you. Dhaval
Yeah.
and Meela Madam, your concluding remark after that.
Yes, yes, yes. Just vote of thanks.
Yes.
So I'm extremely thankful to both the conveners, Dr. Neeraj Jadhav and Dr. Dhaval Belvi, for this very, very useful webinar on sexual dysfunction. I'm out actually, but I was still attending in between. So wonderful panel and wonderful talks. I'm sure everybody must have enjoyed a lot. I'm also thankful to the sponsors for this webinar, SUCAM system, and all the faculties. I will just name them. Just a minute. Yeah. So, of course, the moderators, Dr. Neeraj Jadhav and Dr. Poonam Mishra, and all the panelists, Dr. Indu Singh, Dr. Parul Sauji, Dr. Vaidehi, Dr. Vandana, Dr. Siddesh Iyer, Dr. Madhu Kiran, Dr. Vidya Bandukwala, and the wonderful talks by Dr. Queen Aditya, Dr. Naisargi Patel, and Dr. Shama Sultana, and the chairpersons, Dr. Ankesh Saitia, Dr. Sargam Soni, Dr. Namrita Sheregar, Dr. Ashlesha, Dr. Gautam Sonavne, and Dr. Pranita. So thank you so much for this wonderful program. Neeraj, thank you so much for having this webinar with us, AFGIs.
Thank you. Thanks to our
yes, all
MOC,
the
Dr. Dhaval.
Thank you very much. Thank you for the
Dhaval,
opportunity.
hats off to you, Dhaval.
He
Thank you
As
so much,
always.
madam.
He is driving, he is outside, but he has managed a very nice show. So thank you, Dhaval, for being there.
I tried my best, sir. Thank you for the
Thank you,
opportunity.
Nitin, Bella, AFG, and everyone.
I had a
Thank
very
you.
great time. Have a great weekend.
Thank you. Thank you. Thank you
Thank
very
you.
much.
Thank you,
Bye.
Nitin,
Bye.
sir. Thank you, Nitin sir, Dr. Jadhav, sir, for inviting us. Thank you, sir.
Rimpa, we can stop the recording.
Yeah.
Rimpa, madam.
Thank you, Neeraj, sir, for the opportunity.
Rimpa, madam, clear net?
Yes, sir.
Yeah, we can stop recording and we can stop the proceeding. Thank you very much.
Thank you. Thank you,
Thank you.
Neeraj.
Bye.
So, Client is really thankful to all the dignitaries present here. Thank you so much for giving us this opportunity to host the session. So, with all due permission, we are concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you,
And
Rimpa. You'll always do a good job.
thank you so much, ma'am. Sir, good night.
Bye. Good night.
That concludes the
Good
session
night.
now.